This conference will now be recorded.
Those notifications just disturb our session tonight. Just a couple of seconds for the rest of the people to join.
Madam, in previous question, I wanted to ask you one question.
Yeah.
If genital herpes is there and patient is asking that should my partner should also check for genital herpes or herpes PCR. So what should be our answer?
Yeah, so we said if she says like my partner needs to check or any test, then we will say if your partner get any sores and any blisters down there, any symptoms like this, then he can go to him. We will then advise to go to sexual health and get checked over there.
Otherwise, it's not needed to check even if he is volunteering.
No, so unless it's like the routine test which is done to diagnose genital herpes, type 1 and type 2, both is to take swab from the lesion, from the ulcers, and that is sent for PCR. And that obviously will be done only when there are symptoms. Yeah, routinely we don't do HSV antibodies just to find out whether this person has been exposed to the infection or not. The test is quite expensive and rare, and that really doesn't give any kind of information which is going to help us to manage this person differently. So we don't offer HSV antibodies just for the screening purposes. It's offered only to these pregnant women because we want to, even if the pregnant women present earlier in the pregnancy, like in first or second trimester, we don't need to do these HSV antibodies in them either because they then have more than 6 weeks still in hand before they will go into labor. Yeah, so they will develop antibodies.
Yeah, and ma'am, my second question, like, what is the doses of cyclovir? Because I'm always confused.
Okay,
We have to continue same like 400 milligram 3 times a day.
Okay, so 400 milligram acyclovir 3 times a day for 5 days for the episode treatment. And then we put them on suppressive therapy from 36 weeks. And in pregnant women, the suppressive therapy will be same as well. So 400 milligram 3 times a day. They will continue to take till birth. Now this particular woman, because she's 34 weeks, when we will treat her for 1 week, she will become up to 35 weeks. Yeah, so that's why we'll keep her on suppressive therapy after that as well.
Okay. So we will continue 400 milligram TID till she delivers.
Yeah, but you can tell, you can explain if time allows you that we're going to give you 7 days it will take to heal your current ulcers, but you need to continue after that as well to keep the virus suppressed.
Okay. And for baby 20 milligram per kg, we have to start prophylactic or SOS.
Okay, for the baby, don't worry and don't try to calculate the doses like that. You can just simply say for the baby will be according to the weight. We will consult either we will consult the BNF or we'll take help from the pediatrician to calculate the dose, but the baby should be put on.
Okay. Thank you.
In part 3, particularly when you are, counseling the patient, try not to play with numbers and percentages and incidences. Okay, rather use the word "it's common," "it's not very common," "it's rare," "it's extremely rare." Okay, like these words, because if you say those, you refer to those numbers and you say the wrong, then you're gonna get, kind of penalized. You might lose a mark. So there is no need, I mean, for the patients to say, unless somebody just particularly asks you, tell me exactly what incidence is, which will not happen, doesn't happen. And if you're stuck up with anything like, so say it comes as a structured viva, yes, you should know from structure point of view, but even in structured viva, if not sure, absolutely just say, I will check the BNF, I will check the guideline. It's not in my head at the moment, and I don't want to, just prescribe wrong dose. So I will check into BNF, I will check the guideline and BNF, and then I will prescribe the dose. You will get the mark for that. All right. Unless you are absolutely 200% sure, yes, this is the dose and this is what it is, then obviously say that in structure discussions. Right, okay, so we go to the next one. So Pramila, is your group here now?
Next is Selena.
Yeah. So, okay, so the next person, please take this one.
Selena. Selena, are you here?
Yes. Should I start?
Yeah, if you're ready, you can start.
Sarah?
Hello, doctor.
Yes, my name is Selena Chaudhary. I am one of the on-call doctor today. So can I just please confirm your full name and date of birth, please?
Yes, my name is Sarah Wilson, doctor, and I'm 36 years old.
Okay, Sarah, how would you like me to call you?
You can call me Sarah.
Okay, Sarah. So, Sarah, I understand that you are 36 weeks pregnant and this is your first pregnancy. And you have attended today in our triage because you have some symptom. Is that right?
Yes, that's right, doctor. I developed a really bad headache this morning, and I was feeling a bit blurry as well. So when I rang to the labor ward, they said I should come in. So I just came in, and they have done some pressure and done some bloods as well.
Okay. So, Sarah, is it okay if I ask you a few questions before we discuss the management options to you?
Yes, absolutely, you can.
Okay, so Sarah, you are complaining that you have headache and blurring of vision. Do you have any other symptom like upper tummy pain that we call epigastric pain?
No, I haven't had any tummy pain.
So is this the first time you are experiencing this sort of symptom in this pregnancy?
Yeah, this is, I mean, my blood pressure had been a little bit of up and down in my last few visits as well, but it was never high enough to be worried about or do any medication. You know, sometimes it was slightly high and then it was normal. So they didn't, you know, they just asked me to keep an eye if I develop any of these symptoms. So that's why I came in, because this morning I really felt bad with a headache.
Okay, so I understand that you have some episodes of fluctuating raised blood pressure. Am I right?
Yeah, there were some in my past visits. Yeah.
Okay, but you are not on any medication.
No, I wasn't started on any medication.
Okay, so is it okay if I ask you a few questions just to know a little bit more about you?
Yes, of course, doctor.
Okay, so do you have any other medical condition like diabetes or raised blood pressure before you got pregnant, or any other medical condition?
No, no,
Okay. Do you have any family history of this raised blood pressure? And
no, doctor.
okay, and are you on any regular medication?
No, I'm not taking any regular medication. I was just taking vitamin D, which I was told to, nothing else.
Okay. Are you allergic to anything?
No, I'm not aware of any allergies.
Okay. Any surgery in your tummy or down below?
No,
Okay. Do you smoke, drink alcohol, or take any recreational drug?
no, doctor. I'm not taking smoking, drinking anything in pregnancy.
Okay. And did you have any personal history or family history of clot in your leg or lung?
No, doctor.
Okay. Are you aware of your height and weight?
Yes, my BMI at booking was 24.
Okay. And is your partner supportive?
Yes, well, I'm not living with my partner at the moment.
Okay. So who you are living with at the moment?
Well, I am living on my own. My mom lives down the road.
Okay. Do you work?
I do work, doctor. Yes, I've just actually started a new job a few weeks.
Okay. Do you feel low and depressive?
No, I don't feel low and depressed, but obviously I'm a bit stressed at the moment because of my new job.
Okay. Thank you, Sarah, for sharing the information. Just I will now check your reflexes. Is it okay, or and check clonas that we just see, because from your history and your examination finding, it seems that you have a condition called preeclampsia. Have you ever heard of this term?
Well, I have read about this. You know, last time when I had my slightly high blood pressure, then I did a bit of reading about internet.
Okay. Basically, preeclampsia is the condition where you have raised blood pressure and protein in your V, and it's a complication of pregnancy. And if somebody gets this high blood pressure together with 3+ of protein, that means you have quite a lot of protein in your urine. So we tell you that you have severe preeclampsia. And are you with me?
Yeah. Okay.
So because of this blood pressure and your protein in your urine, we have to admit you for management here. And as you have quite high blood pressure, we have to have very close monitoring of you, and we have to check your blood pressure every 15 minutes until it gets like lower than this 160 by 110, and we have to send you some bloods.
Can I say something, doctor? Yes, your midwife told me. She gave me paracetamol. My headache is gone now completely. I'm feeling well. I have no problems at all. And regarding blood pressure, I mean, I can't stay. I can't get admitted in the hospital. You can
ask,
see medication for blood pressure. No, I'll just take that home at home.
sorry to ask you, is why you don't want to stay?
Because you know it's my new job, doctor. I just started like about a few weeks ago, and so like I'm living on my own, and I really desperately need to keep this job.
Okay.
I can't take time off at this stage.
Yes, so I understand that, but at the moment, your condition is quite like critical, because your blood pressure is quite high, and we always fear if anybody is this high of blood pressure, she might develop convulsion and you might develop eclampsia when you have raised blood pressure. So I will just recommend you that you have to stay in. I am informing the labor ward. You have to monitor there, and if you need, we can also call your midwife or your workplace that you can go today, and then we will send you some blood, and we would we will check your liver function test and your kidney function test. We will send your urine just to count that how much is your protein in your urine, and also I will start antihypertensive now. Initially I will give you orally in like high dose, but if it doesn't control, then we have to give you in we will have to put a cannula, and then we have to give it through your vein. And because
So
you have
I'm okay to stay maybe another couple of hours, and I can start taking the tablets which you give me. I
okay,
live here to the hospital. You know, if I will have any problems, I'll come back.
okay, no worries. Let us follow you up and check your bloods, and then if your blood pressure becomes settled, and then we might discuss for going you home. Is that sounds okay?
Yeah, okay.
Okay, so I have to just involve my consultant also, because you are severe hypertension, and I will also inform my midwife coordinator that we are shifting you from the triage to the labor suite, and we might need to give you a medication called Maxal, because if you have so much high blood pressure and symptom, you might develop eclampsia. So we will ask you to stay there, and we will give you that one also, Maxal. Does that make any sense?
Yeah.
Okay. So I'm just sending your bloods and making you arrangement to shift in our labor ward and the high dependency bed, and then from there we will see.
Right, okay. So how long it will take all these tests and stuff, like would they be done like in a couple of hours time?
Yes, I'm sending them urgently because you are quite yes, that we can know how you are, and we will check your blood pressure to see is it going down, and we will recommend you to stay here for at least today, then we will see how it goes.
Well, no, doctor, as I told, I can't really, you know, I can't
Okay,
stay.
okay, so I understand. I am not. I'm with you, but just can we do the management now? Then we will see whether you can go. We can release you.
Yeah.
Okay, and I'm also contacting my consultant so that you can have all your concern addressed by him.
All right, okay.
Okay, thank you.
Okay. Right, Selena, thank you very much for trying this station. You still had 1 minute left. Okay. So yes, I think there was a bit of other medical jargon here. Reflexes, reflexes, okay. Clonus and Caesars, these things. So try to change them into simple words. Domestic violence or abusive relationship. Somebody is pregnant, 36 weeks, and leaving her alone, not living with the partner. Where is the partner? You know, what happened, right? Okay, separated. Just make sure, you know, what was the reason? Was it like kind of a bit nasty breakup or what? I mean, this person might have been a subject of domestic abuse from their partner. That's why she's living in a different place. The partner might have been working in this hospital. That might be the reason she's not getting admitted. Yes, she said due to the work, but then she still. So I would like to explore a little bit more. Yeah. So that's why we say it's absolutely important to make sure to explore the domestic violence or the violent sexual relationships. It's not unusual for people to actually, because you know, when you read about and you talk about the domestic violence and stuff, then you say the women at a high risk of having domestic violence when they're pregnant. Yeah, so it's not unlikely that at that stage then they get either separated from the partner or they've disclosed it to somebody. I mean, I wasn't going to take this towards domestic violence, but that will be fatal mistake not to exclude. And also, okay, so then you did nicely, you told me I can have these complications, but I still didn't quite agree to stay in the hospital because yes, you told me I can have a seizure and I can have severe preeclampsia and this one. And to be honest, I didn't understand what these seizures are, what their significance is, what harm they're actually going to cause me. If you would have taken me a bit more further to say, and you know, you can have developed a sudden fit, which can be life-threatening for yourself and also for your baby, then I might would have, you know, said, oh, right. So because I'm not aware actually, the seizure or whatever the complications or stuff can happen, when I go, I was not able to weigh it. So I still feel I can go home after a couple of hours and do, you know, my work, continue with the work. So that's also important. Then we are explaining them. So obviously, if even after that she doesn't understand, she doesn't want to stay, then it's fine. Absolutely, yes, we will send her. Obviously, we can't keep her, but obviously, then we need to. So as long as you understand, you know, that not staying actually can lead to this severe complication. This can be life-threatening for you and your baby. If you still want to go ahead, to go home, then it's okay. Yeah. So our duty is basically, if somebody is taking some decision which we feel obviously clearly is not in the best interest, then first we need to explore the causes and reasons why this person, which otherwise seems to be quite competent, is taking that decision. Yeah, and then we offer the support and give her the solutions what we can actually do to address her concerns. And if she still wants to go ahead, then it's fine. That's her right of autonomy. Then that person can go. Okay, so let's start on the how we will do this one. So this type of typical scenario, this is also coming in the form of where basically your junior is coming to you like your FY2 or ST2 with all this information basically. So this person has attended on the triage in the morning and your junior has assessed this person, all the stuff, and now the junior comes to you and say, I have seen this woman with this, and she's insisting to go home. Okay, then basically you will need to again take the same history information from the junior, but the way you will present, you will deal it. You know, I think I discussed that in my free session as well. But the way you will say to the junior, first of all, you will recognize this is an emergency and this patient needs to be immediately seen by yourself. So the first thing you will say, thank you that you came to discuss with me this patient. And yes, this woman is. So with the junior colleague, you can use the medical jargon. Yes, this woman is in severe preeclampsia and she is at a risk to develop eclamptic fit at any stage. So I come with you to see this woman, and then obviously we can explore her reasons why she doesn't want to stay and address them accordingly. Yeah, and then at the same time, then you will start taking the information from the junior, which you will take from the woman in the form of history. Okay, so then you will say, okay, so in this, so if you're taking as a role player, so to the woman you will say, okay, I can see you're 36 weeks pregnant, you came this morning with a severe headache. And then just give her first couple of golden minutes to talk and just ask, okay, would you like to tell me about your headache and are these symptoms you should develop? When did you develop exactly your headache? So she tells you, okay, I developed this morning and this is what's happening. So she has a blurring of V and ask her about, now you keep other signs of preeclampsia in your mind, which can be epigastric pain, or it can be, you know, there will be edema and the colonus. But you see, the way we will ask for the patient will be, have you noticed any pain in your upper part of the tummy? Yeah, we won't say epigastric pain. So have you noticed any pain in the upper part of your tummy? And is it the first time you're having all this symptom and your blood pressure is found to be high, or you had that before as well? So then she tell you, okay, during my pregnancy it has been fluctuating up and down, but I was never good. And then you say, okay, so I'm going to have a good look into your antenatal notes as well to see what your blood pressure range has been. Okay. And then you can ask, okay, so I can see when you came in, your blood pressure was quite high, and there was some protein in the urine as well. So has your blood pressure been rechecked since then? Yeah, so this could be admission one. Has that been rechecked since then, and what their blood pressure was, if it is, if she can give you any information, or if it's your junior, you can ask, has the blood pressure been rechecked since then? But obviously this blood pressure is an indication starter on antihypertensives. So to the women, then you will ask about this history, then go about the other, how she's feeling now. Is she feeling any blurring of vision? then ask her to say, so to discuss with you the management plan, I need to have some more information from you. And the information will be, you have taken the information specific to the condition, now take the other history which you did nicely to ask, do you have any other problem in your pregnancy too so far, like diabetes or any sort of other health problems? Has there been any concerns about the well-being or growth of the baby? So when we say this particular sentence, that means we are overall asking to the whether it's your junior or the patient about, they will actually tell you then if there has been any additional thing we are doing, monitoring, like growth restriction or anything like that at all, or any abnormal placenta position or anything. And then you can just simply ask about as well, have you other all the blood tests, your routine pregnancy blood tests and 20-week scan been reported normal. And then do her VTE risk assessment, history of blood clots, BMI, VGT task, history in the family. Then come to her mood and things. You said like, okay, have you been feeling any low, stressed, or depressed in last few weeks time? She told you, I have been quite stressed because of my new job and all that going on. And then you can say, so okay, I can see that can be quite stressful. Acknowledge, and say, is there any other reason which is contributing to that at home or in your working environment other than just a new job? Yeah, so explore a little bit more. She might then come up with something she's been worried about, what the partner has been doing and stuff. And then we come to ask that question where we exclude our domestic violence by asking, so are you, is your partner, is your partner supportive, and do you feel safe and happy with the partner? And then obviously if there is anything going on, she will volunteer here by saying, well, I'm not living with my partner, I'm living on my own. Now obviously she got pregnant with some person, we need to know then what is happening. Yeah, so this person still might be coming because she's carrying his baby or whatever. Then we need to know by saying, and then you can say, if you don't mind me asking, can I ask you, was that separation, was their relation abusive at all? Or since you've been separated, has there been any, abusive threat or any, concerns, ongoing concern from that relationship? So just ask clearly in very simple words, yeah? So if there is anything, she will say, and if she says no, there was that, whatever, then it's fine. That excludes you that bit. Then you don't need to worry about it. Then your rest of the routine history, any other medical health conditions she has, any family history of high blood pressure or a condition called preeclampsia. Yeah, so you can say the high blood pressure and a condition called preeclampsia. So exclude that one as well. Surgery, medicine, routine, your allergies and stuff. Then start her explaining the condition. Then you could say, so I can see when you came in, your blood pressure was very high. So what happens when the blood pressure is high in the pregnancy? It can affect the kidneys. It can affect the kidneys. It can affect the liver. Okay, and as a result of that effect and damage to the kidneys start releasing or some secreting or releasing protein in the urine. And that means that this blood pressure is significantly high enough to cause damage to different organs of the body. And at that stage, then, if somebody's the way we measure that protein in the urine, we simply say 1 plus a protein or 2 or 3 plus a protein. 3, you had high blood pressure 160 and 110 with 3 plus a protein, which means your blood pressure is significantly high and it has started causing damage to your kidney, and it can affect your other organs as well. The women with this much of high blood pressure and protein, losing protein in the urine, at a very high risk to develop a fit. We call this eclampsia. Okay, they can go into fit or seizure. We call it eclampsia, and that can be life-threatening for the woman and for the baby. And for that reason, we strongly recommend these women to get admitted into the hospital so we can start their close monitoring. At this blood pressure, we will start you on the blood pressure control medicines, and also to start you on a medicine we call magnesium sulfate through the drip, and that medicine will reduce your risk of going into the fit. All right, how you feel about it? And then she says, no, I can't stay because of it. So can I ask you the reason? Is there particular concern you can't stay in the hospital? Yes, because it's my new job. And I can't take time off. Then we need to say, well, do not worry about that. So we're not going to say our midwife will call at your workplace. No, nobody can call it there. Obviously, we're just going to give her a sickness note. At 36 weeks, she is able to start her maternity leave now anyway. but maybe because she's new in her job, she's not entitled to maternity leave or whatever, and that's what she's worried. Then we can say, well, this is your statutory right to take time off, okay? And no employer can actually, penalize you for that. So we will give you, you should be entitled to have your maternity leave and start your maternity leave from 36 weeks now anyway. But if you can't, we can give you the sickness note. But it is very important that we keep you in the hospital. Otherwise, it can be life-threatening. Okay, so once we will reassure her from work point of view as well and give that information, then she should be okay to stay. And then you can start explaining her the management, what we're going to do. Okay, so you will be, we're going to monitor you very closely. We will be continuously, we will put a monitor and continuously keep an eye on your blood pressure. We will measure your blood pressure. We will also check the amount of oxygen in your blood. At this level, it's also important that we keep a record of whatever you're drinking and whatever you're passing out as a urine, because your kidneys are showing some effect from the blood pressure or some damage from your high blood pressure. Okay, so you have said about intake output, you have talked about magnesium sulfate, you talk about your antihypertensive, you talk about continuous monitoring. You will have one-to-one, monitoring by the midwife. I'm going to discuss this with my consultant as well. Once we have stabilized your blood pressure and all that, then we may then discuss with you the plan to deliver the baby. Yes, she's 36 weeks pregnant already. She's a 30-week gestation, and if she's that bad pre-eclampsia and also preeclampsia, we can actually induce her. So we may not be sending her home. Okay, so I won't be even saying we will give you 2 days at this thing. Yeah, then we just simply will say if your blood pressure really comes to control, we may then actually decide to deliver you, because these changes in the blood pressure, they are supposed to be, or we feel they are because of the placenta. So the ultimate treatment and the management is to deliver the baby and deliver the placenta or the afterbirth. we also need to start monitoring the baby closely. So what I'm going to do, I'm going to put a continuous heart monitoring trace. As I can see from your scan, shows that your baby is growing smaller. I will check with the sonographer if they have done further testing for the baby's well-being, like monitoring the blood flow towards the baby. If not, if they've done that, I will take that information. If not, then I will arrange for their special scan as well. We would like to measure the blood flow to the baby. We call it umbilical artery Doppler. And then according to that, taking things that we will keep an eye on the baby's well-being as well. If the further monitoring of the baby shows that the baby is also showing the effect, baby is also affected by this high blood pressure, and the baby is compromised, then we may then discuss with you to deliver this baby. Okay. So this is the for the time being plan you will do. Okay, and then you need to obviously say that I'm going to do some blood tests. I'm going to repeat your blood test as well for your liver, for your kidneys as well, because this condition can also affect the liver. It can also affect the clotting ability of your blood. So I will send some bloods to check that as well, your clotting and bleeding factors and the ability of the blood as well. Okay. And that's then it's fine up to here. Your initial management plan. You have talked about antihypertensive, magnesium salt monitoring, repeat blood pressure, and yes, you need to talk about that. I'm going to check your, because this high blood pressure, this can also irritate the brain, and as a result, there can be some changes. What we call the reflexes of your joints, so I will be checking those as well. That also we will need to keep an eye on the because we're starting on a medicine called magnesium sulfate, and magnesium sulfates can have some side effects and toxicity. But don't worry about that. We will explain you that everything as we are going along, what is going on, and we will be monitoring you for everything closely. All right, and then you can ask if you have any questions at this stage. I'm also going to give you some written information, so when you start feeling a bit better, you can read about it. Otherwise, don't worry about it. Any question you have in your mind, you can ask us. Midwife will be with you all the time now, monitoring you till we are happy that you are well stable. So yeah, so that's what we will do. We will put her in a high dependency room. Now I'm just giving you the information otherwise, right? So the station is closed, you can imagine. So she will be kept into high dependency room in the labor ward, which we do have for these preeclampsia. She will have, the one-to-one care, but the midwife will be there all the time, she will be on a continuous monitoring for blood pressure. she will be, we will start doing intake and output record. We will do the protein proper quantification of the protein and send for PCR and also all the bloods to exclude any HELLP syndrome already. The baby's scan is given. You need to have the Doppler of the baby as well and the CTG, and then with that can also affect our plan regarding the to discuss the timing of the delivery or even mode of delivery. Okay, so with this one, we probably will stabilize this woman and then induce her maybe in a week time or so if she get even stabilized. After, if not, then, then obviously we will have to go for delivery even earlier than that. Okay, any quick question?
Dr. Safia?
Yeah.
As this is a case of severe preeclampsia, so should we do this case while doing communication and management side by side, or first taking history and then explaining the
Yes,
management?
so because this is the, if it's role player, then it's fine. That means with this high blood pressure, she's already, I mean, although she's on triage, but she's in the hospital, she's there. You can just quickly explain. If it is the case as your junior coming to you for discuss this one, then when you say I'm also coming with you to see this patient, that means you have started the management then. Okay. And then you will just explain her by saying because she has this hyper and she has a proteinuria, she is with preeclampsia, and preeclampsia then can lead to eclampsia and the fit. So all that information which you were given to the patient, you will be actually kind of discussing with your junior. The history which you are taking from the patient, you will be asking that information from your junior to say, have you asked this? Does she have this? Any problem? Why she doesn't want to stay? Is there this? And then just clearly say, we need to make sure, are there anything else going on other than work which she's bothered? And if she's not with the partner, what's happening there actually in the relationship? Was that like some kind of, abusive relationship? And what's going, is she still feeling insecure and any risk from the partner? So this is how you will then just say the same things to your junior. Okay, next question, one more question, and then we go to the next one. Right, who is next?
Sadia.
Sadia was a night, so I think Sadia is not here. At least not
Neelam.
present. You sent her apology.
Neelam.
Okay.
Yes, doctor.
Let me just see what we got. Okay. That's the next one. Okay, your 2 minutes start now. Okay, that's the first 2 minutes.
Okay. Hello, I'm Dr. Neelam, one of the doctor on duty today. May I confirm your name and age, please?
Yes, doctor, my name is Joanne Marsden, and I'm 30 years old.
So how may I address you?
You can call me John.
Okay, John.
So
So
sorry,
I
I'm
can see,
changing the age of gestation. Okay, we are making it 30. Okay.
okay.
Yep.
Okay, John. So I can see that the community midwife has sent you because she has some concerns about the size of the baby. And you are here to discuss the management options. Is that right?
That's right, doctor. The midwife told me the baby is actually measuring larger than what it should be. And then
Yeah.
she booked me a scan, which I have done, and then they wanted me to see in this clinic. So here I am.
Okay. Okay, John. So before we discuss with the management plan, may I ask you a few questions to know more about you and
Yes,
may
doctor.
examine you?
Yeah, yeah.
Okay. So, John, can you tell me about this pregnancy? Everything all well till now? Any concern till now?
No, I mean, it has been going straightforward. Everything is okay. No issues.
Oh,
You were just
okay.
that the baby is growing bigger now.
Okay. That's good. All your booking bloods and anomaly scan and all were normal. Uh,
Yes,
and your blood pressure was also normal. Okay.
yes,
So,
it has been.
you are taking some medicines?
No, I'm not taking anything. I'm just taking those pregnancy vitamins.
Oh, vitamins, that's good. Okay, so is this your first pregnancy?
No, this is my second pregnancy.
Okay, can you tell me about your previous pregnancy?
Yes, my first pregnancy was well, that was about 8 years ago, and that was pretty straightforward. I didn't have any issues, any problems.
Okay, so
Yeah,
weight of the baby was? What was the weight of the baby?
there was a chunky baby. My baby's weight was like about 8 pounds.
Okay, that's good. Okay, so that was normal vaginal delivery and no concerns or no complications, right?
Yeah, I had some stitches down below.
Okay,
Yeah,
okay, okay. So, okay, and what about your blood group?
my blood group is A positive.
Okay, and what about your weight to height ratio?
My weight to height ratio is 35.
Okay. Okay. Any other medical condition of concern, like diabetes or any high blood pressures or any
No,
clots
doctor.
in lungs?
No,
Okay.
I did a
And
test to check for any diabetes and stuff, and they told it was normal.
okay, so that was done how many time back? Which time back? At which gestational age?
So they did
You
one about when I was about 26 weeks pregnant, and they
okay?
one yesterday as well.
Okay. So any family history of diabetes or any other high blood pressure or clots in legs or lungs?
No, doctor.
Okay, so any surgery on tummy or down below?
No, doctor. I never had any operations.
Okay, so John, do you smoke?
I was smoking, but obviously I stopped during pregnancy.
That's very good. Any alcohol?
No, doctor. No, I'm not drinking in pregnancy.
Okay, so what do you do for your living?
I'm not working at the moment. I lost my job due to COVID.
Okay, so whom do you live with?
I'm living with my partner and my, 8-year-old child.
Okay, so everything well at home, no?
Yeah, Yeah, all is okay.
Okay, so any other information you want to add, John?
I can't think of anything, doctor. Obviously, I'm just a bit
Okay,
worried. The midwife said, the baby
okay,
growing bigger,
yeah,
I may not be able to have vaginal birth or something like that. So I was really worried because I'm
yeah,
really
yeah, John.
vaginal birth.
Yeah, I can understand all your concerns. So, John, actually looking to your history and examination, there is no significant factor which can lead to high birth weight or large baby. Like usually it is large for gestational age in cases of diabetes, but your blood tests have been normal till now, and your fluid around your baby is also normal, and there are no tests suggestive of any reason for any large baby, any reason for the baby being large. So it might be just that your baby is growing, that may be normal for you. So, but having a large baby may have some problem during delivery. So what may happen that we'll repeat the sonography ultrasound scan at around 36 weeks to see whether it is still growing towards higher side, and then I'll discuss with my consultant and we'll discuss with the delivery plan at that time. All right.
Right, okay.
So usually the ultrasound scans are not 100% accurate of the birth weight uh, or the weight of the baby. There may be 10 to 15% up and down in the actual weight. And we'll look again at 36 weeks scan. And at that time, if the baby size is high, then at the time of delivery, there may be risk of prolonged labor. There may be risk of instrumental delivery at the time of the second stage. And also there may be tear down below, and sometimes the head may deliver out but the shoulder may stuck, and that may become a very dangerous situation for the baby as well as for the you, right?
All right, okay.
So at that time it becomes a panicky situation. The baby's nerves may compress, there may be some bone injury also. So and that cannot be predicted, although it can happen in lower birth weight babies also, but its chances are higher with large babies.
But that
Also
sounds
after
very horrible,
delivery,
doctor. So
sorry.
that sounds pretty horrible. So will
Yeah,
it be safe for me then to deliver this baby by cesarean section? I mean, I don't want to. I got 8 years older
yeah,
daughter as well. But if you think the vaginal
yeah,
delivery will damage my baby so
yeah.
badly.
Yeah. I will talk to my consultant, and the timing and mode of delivery will be discussed again at around 36 weeks with you. And if safest would be cesarean section, but if you want to go for vaginal delivery, then my consultant may, with your consent, like to induce your labor at early gestational age, like 39 weeks, and the pros and cons will again tell you of cesarean section as well as the vaginal delivery at around 36 weeks. And so that's why we would recommend you to go for consultant led unit, that is in the hospital delivery, because there may be risk. And
Okay.
after delivery also with large baby, there may be risk of heavy bleeding that have to be controlled, because the uterus womb may not contract, or there may be some trauma to the perineum, to the lower down below, and that we may have to stitch. So looking to all these things, it may be recommended at that time that the safest option for you may be cesarean delivery.
Okay.
How do you feel about it? Uh, you
Yeah,
getting
well,
me?
yeah, of course,
Yeah.
doctor. Yeah, if that's what I need to do, because yes, this vaginal
So
delivery sounds very horrible
yeah,
to me with large baby then.
yeah,
Okay.
yeah, Jones. So I'll give you the information, written information leaflets, and I'll make an appointment with my consultant at around 36 weeks. We'll do again your scan, and till then, mm, you continue taking your medicines and Take care. Is there anything else you want to ask to me?
No, I can't think anything particularly, doctor, other than obviously the questions about now
Okay.
the delivery of
Thank
the
you,
baby.
John. Yeah, thank you, John, for all your time.
Thank you. Thank you. Was it Neelam? Neelam, thank
Yes,
you.
ma'am. Yes.
Right, yeah. Good, good, good. You did nicely, but I think you did like about, I would say about 70% of this patient. And the reason for that is you completely forgot I have a BMI of 35. Yeah.
Oh, yes, yes, doctor. Yeah, 35. Yes.
Okay. So
Yes.
yeah,
Yeah.
so this is something, and I have intentionally not written the BMI in the notes, and I added it as a history, and it's not unusual. I mean, yes, in the real scenario, you will be able to see the women being that big sitting in front of you, but still, you know, if you have asked me the question of BMI, why we asked that question? Yeah, we said we asked that question to do VTE risk assessment. So if we have asked that question and she has told us she has a risk of, then we need to talk about that. But to say, okay, so you know your BMI, your weight is towards higher side, and you know pregnancy itself also increases the risk of blood clots in legs and lungs, and then if weight is more than certain level, that also contribute further, you know, to increase the risk. So what I will do at the end of this consultation, I will do proper your risk assessment for the clots, and then we will start you on some appropriate the measures. We will take some appropriate measures to prevent your risk. You know, it can be in the form of even some tight stockings, or you know, just to encourage you to drink more water and have more exercise regular and walk around. Yeah, so you must address that one. It was dangerous statement to say we can't see there is no reason or cause for your big baby. 35 BMI is one of the causes of big baby. Yeah, so I will say, you know, I just said as well, try to keep things as much simple as you can. Unless the role player, particularly when you're doing with the role player, unless they particularly asked you for something. Yeah, so we can just, I wouldn't say, I mean, there is no reason and cause for that baby being big. So that's about that. And then obviously they become like two parts of this scenario. Then one to address large petite baby and how we're going to monitor her pregnancy from here onward. And the other one is because of high BMI, do we need to do anything different? So obviously anesthetist assessment at 36 weeks, and then that really risk assessment, and we say that further increases the risk of shoulder dystocia. So when I said like, okay, so if I go, it sounds horrible to deliver this baby by having vaginal birth because of you know, the shoulder dystocia risk when you explained. And then I said like, I feel it will be safe, then I would rather go for, you know, cesarean section if that's more safe. So the answer was yes, cesarean can be. No, we can't say, we can't say. I mean, the risk of shoulder dystocia is not reduced with the cesarean section either. Still, there can be. The way to answer that question is to say, so what we're going to do, we're going to monitor the baby's growth pattern and also the weight of the baby. And if the baby's weight goes above certain limit, we usually recommend to go for cesarean section to reduce the risk of, shoulder dystocia. However, the risk still will be there. However, it's more likely to deliver baby safely when we come across the shoulder dystocia during cesarean section as compared to vaginal birth. Okay, so it is very important then to listen what patient is saying and then answer their concerns accordingly. We don't need to get overwhelmed to go to the fixed pattern, what is going on. Yeah. So, okay, to start with, just introduction in the beginning. Okay, before I forget, one of the previous, no, I forgot the name. Some of you started by calling the women's first name straight away. Say, for example, John, can I take your full name and date of birth? And then you ask, by taking the name again, John, can I ask you John? So please be careful. Always start the women with the full name, John Marsden. Can I, you know, confirm your name and date of birth? And then you ask, how would you like me to call? Don't give a leading question, yeah? Because we have already basically started calling her Joanne without taking the permission. And then we ask him, would you like us to call? So just these little things, they don't penalize you with the marks, but they do overall, on the mannerism. Right, okay, so after name and everything, then you can say, okay, so I can see you have a scan done, and then you're here to discuss the scan report, and then you can just simply, invite her to talk first to say, would you like to tell me what your concerns has been? And then she started, okay, my midwife did this. She said baby was growing larger, and that's why I had this scan done, and they said the baby is growing larger. No, obviously the scan tells us about saying that this is the first scan, which says, that it is 90th centile. We know it's the growth pattern, okay? So I'm sorry, I did change the gestational age as well, because I wanted to see if you understand the how we need to respond according to what the patient is saying and the situation, rather than just thinking, yes, this is that recall which I have heard and practiced already. Okay, so this woman, what we will say, yes, on the baby, I'm just kind of had a look. Yes, the baby is growing towards the larger side. This is what we will say at this stage. And then we will say, so what we do basically, we, measure the baby's growth, the baby size and the weight as well. And then we just, make a kind of pattern, a plot. And it says, it shows that yes, your baby is growing towards the larger side. However, I will say, don't get alarmed just on one single scan that this baby is growing larger. We are going to actually monitor this baby's growth pattern over next few weeks. So we will repeat the baby's growth scan after 2 weeks again. So from 30 weeks, we can't leave her up to 36 weeks, okay? So we're going to do that after. So she's going to have 2 weekly scan for growth. And then the other thing you need to tell is that the more reliable criteria for us to label some baby as a large size baby, a small size baby, is to do the estimation of the weight of the baby as well. I do not have that information here on the scan report I have got. So I will check with this ultrasonographer, with the sonographer. If they have done that, that's fine. Otherwise, I will request that calculation to be done as well. Okay. And then you say, and the rest of the parameters are, the scan report shows that the baby's overall well-being is okay at this stage. The water around the baby is fine. However, as I said, like, we will need to keep repeating this ultrasound after every 2 weeks to measure the growth pattern, the weight, and also to measure the blood flow to the baby to make sure the baby is, growing satisfactory. And at any stage, if we have any concerns from the weight of the baby, that if this baby is growing a little towards a larger size, where the vaginal birth may become a problem, then we will discuss, the mode of delivery with you. Sometime when the baby's weight goes more than, it goes up to like 5 kilos, then we recommend to deliver those baby by cesarean section. Okay. And then you can tell her the risk associated with the large size baby and start from here now onwards. So then your history taking was fine, that was good. And then you did ask about the GTT. She told I has at 20 weeks because, because I'm a large size woman, so obviously I would have been given at 26 weeks, and then I have yesterday as well because of the large baby, which was all fine and normal. But no, you still need to think about it. 35 BMI woman, this woman is at increased risk. Even if she hasn't developed any high blood pressure, she still can do. She's only 30 weeks pregnant now, right? So she still can be at risk of developing, preeclampsia, high blood pressure, or VTE, anything. So we need to talk about that as well. So let's do the large gestation size baby first, and then we will talk about maternal risks. So then we'll say, okay, so the babies who grow larger, there can be some complications for these babies during the delivery process and immediately after the delivery as well. So the baby who are larger in size, the labor may be a bit more prolonged because the womb is not able to contract as forcefully as it should do during the labor process. That may take a little bit more longer for the labor to be completed. And then, so keep thinking about first stage, what problems we can have in the first stage, then think about what problems can be in the second stage. And then you can say, so then when, the baby is about to deliver, like the neck of the womb is open, and sometime then still there can be a problem for the baby's head to come down. and deliver. So sometimes we need to give assistance to deliver these babies with some instruments. We call them as a four-sector vacuum. We will speak to you in more detail if we need you to do that. Just mention about that. So instead of instrumental delivery, just clearly tell the words so she can make a little bit more understanding. We may need to give you assistance to deliver the baby with this, and then we may need to give a small cut in the raw part as well, just to create a little bit more space inside the vagina. And then large size, with the large size babies, there can also be a risk that once the baby's head is delivered, baby's shoulders can get stuck. And then that requires quite specialized maneuvers to deliver the baby. I wouldn't say it's an emergency and all that, because she will become too much alarmed. Yeah, it's for us. We know that will be an emergency situation, right? All we need to say to her is like the shoulders may get, which requires specialized maneuvers. However, we are trained to, do those maneuvers and deliver those babies if they happen. But there can be some complications associated with that. Sometimes there can be a risk of injury to the baby. You can say the baby's collarbone, some damage to baby's nerves. And we won't go into too much detail beyond that, because we see you will run out of the time. And then once the baby is delivered, after that, there can be a risk of heavy bleeding from that womb, because the womb with a large baby obviously has to contract more forcefully and all that. And as a result, that womb basically kind of become quite exhausted after the delivery, and it doesn't contract as forcefully as it should do to stop the bleeding. So as a result, obviously, there can be quite heavy bleeding. However, again, we are aware of that, so we will give you, we'll keep an eye. We will be ready to prevent that from happening by giving you some medicine and starting putting you on some drip, which will help to keep your womb really strongly contracted. Okay, so that's about, you have covered now the shoulder dystocia, BPH, and all that stuff. So there was another thing I said when you asked me first delivery. I said yes, the baby was a bit chunky baby, but I had stitches down there. Even if it wasn't a big baby, if somebody says I have stitches down there, it just become natural for us to then ask, was that some small tear? Was it a planned cut was given? It was just a small tear, or it was some tear which extended up to your back passage? Right, that become quite relevant and important as well. So just simple normal things. Yeah, if she's saying something, just stay with the patient in the tune and just ask a little bit more detail or information if you think it could be something to do with our management plan. And that's about the life size baby. And then regarding her BMI, I will touch a few things on that, what I will say, because your weight is towards the higher side. There can be some risk of developing high blood pressure till the time of delivery or after. So what we will do, we will keep an eye on your blood pressure as well. So I'm going to check, I will make sure we check your blood pressure today, and also check your urine for the presence of any proteins in the urine. At any stage, if you develop any symptoms of headache, any blurring of vision, any pain in the upper part of the tummy, any swelling in your legs, which could be a sign of blood clots, please immediately contact us. Yeah. And then say, what we will do then at 36 weeks, I will arrange your appointment to be seen by our anesthetist as well, so that you can just do, some assessment in case during your delivery, or if we have to go for cesarean section, if we need to give any anesthesia, or, we will need to pass the cannula for your birth as well. So you can just do that assessment for his plan of anesthesia as well. When the baby will be born, baby will be seen by the baby doctors, right? So from BMI point of view, obviously, other than continuous monitoring, we will say the baby will be continuously monitored. And then once the baby is delivered, the baby will be seen by the baby doctors, because the babies who have larger size than average, their blood glucose levels can fall very quickly. So baby will be seen by the baby doctors, and then it will be important to start feeding baby quite immediately after the birth. After the delivery, we will again assess you for your risk of blood clots in legs and lungs, and then we will, start you on any preventive medicines or stockings or whatever will be appropriate according to the risk assessment we will do. All right. We will discuss the contraception, some safe and effective contraception method with you as well to start after your birth. Because it's important that you do have a appropriate gap between two births, and also have a planned pregnancy rather than unplanned, because sometimes when your weight is towards the higher side, or your one baby is born with a large size, sometimes we may need to take some extra care of your pregnancy right from the beginning. All right. Thus, you have now taken her to home till next pregnancy plan. Any good
Yes, ma'am.
question?
Excuse me, Dr. Safia, I have one question.
Yeah.
Hello.
Yes.
Yeah,
Yes.
Dr. Safia, if she's asking for that can I, if and if the growth is faster, so if I deliver before time by artificial pain like that, so why not to talk about well before that?
There was a lot
To
of
wait for
interruption.
5K offer
Sanjila, I just
cesarean.
could not understand your question.
Okay, just hello. Can you hear
You
me?
wanna say it again? Yeah. Yeah.
Okay, okay. My question is, if she's asking for that during the monitoring, if you found that my baby is growing faster, so why not to deliver before time? Why to wait for till 5 kg and have a cesarean section? I don't want cesarean section at all, like it was my patient and asked me. So shall we
Yeah,
talk
so
about
that
that?
depends what gestation she is. So, I mean, here obviously I made it 30 weeks. If she's like about 36 weeks or 37, then the answer is still the same.
Yeah.
We do not have the weight estimation at the moment. So we're going to get that information, with weight, and then we can inform her, like, you know, up to, we will not encourage to deliver baby vaginally once the baby's weight goes beyond 4.5 kilos. And then we also, obviously, we will be monitoring, keeping an eye, but we would also like to achieve a balance between, how long we can wait. Because if we try to deliver the babies earlier than certain time period, that can obviously increase the baby's risk of mortality, like developing the breathing problems and infection and even death. The severe breathing problems. So we will need to keep that balance. So, as we will keep going with the monitoring, we will keep updating you with all, and then we will, keep you informed, and we can always discuss what you want to do. And it will be done as you will like after all the information given. So at this stage, I wouldn't say, yes, I can wait. And if she was like 36 weeks or 37, I would still say we would like to take you up to 39 weeks minimum. Yeah, because that's what we know from our, and we will not like you to go post dates, like beyond 40 weeks. So I'm not going to promise her any weeks at this stage. I will say we would like to take you at least up to 39 weeks and not let you go beyond 40 weeks. However, when we should deliver, that will all depend how the baby is overall doing and how the baby's weight is being, after the calculation. And then we'll discuss with you, every time. And then we will take your wishes in consideration as well. So I wouldn't go into that discussion at this stage. I will just reassure her, yes, we will try to give you a vaginal birth.
Yeah, this is like it's mentioned in the strategy as well, that 38 to 39 in between you can deliver her by doing IUL, and it won't increase the risk of cesarean and all that. So that if she's 36, 37 weeks, you can discuss these things with.
Yeah, so you're not going to say that we can deliver you by after 38 weeks. All you need to say is, this is what we're going to do. This is our aim, to take you up to 39 weeks, not beyond 40 weeks. But then depending on your weight, we will discuss with you. That's it.
Yeah. Okay. Thank you very much.
One more quick questions before we go to the next one.
Dr. Safia, in a person with a high BMI, isn't there an increased risk of stillbirth after 39 weeks? So we have to do induction of labor by 39 weeks, no?
With 35 years. So with the weight, because here again, we won't be promising any particular time of delivery, because at the other side, we are having a large size baby going on as well. Yeah. So yes, in this
39 week or 40 week we will induce it fetal macrosomia.
With fetal macrosomia, okay, you guys complicate things. Okay, listen, girls, listen. Aim will be to take her to at least up to 39 weeks, not let her go beyond 40 weeks. And when I say that, that mean if we obviously at the same time we're saying as well, like if the weight goes more than 4.5 kgs, we will like to deliver you, and if it goes up to 5 kg, then we will be delivering you by cesarean section. So what we're telling this woman is that these will be 3 factors we will be keeping in account to make a decision when will we deliver you. Okay. So at this stage, I can't say to her, you know, even if she's 36 weeks, I can't promise we can deliver you at 38 weeks. I do not have the weight of this baby from this information given. Yeah, I don't have the Doppler reports with me to see if the baby is compromised or anything like that at all. CTG is normal. So I'm just going to discuss the same I did, like we will speak to the sonographer, do the weight calculation of the baby as well, and then, you know, take things from there. So now we're moving to the next question, next scenario. You can put that into group if further any confusions regarding that station. Okay, who is next, Pramila?
Reena.
Is it Reena D? Reena D is not in.
No, Reena.
Other Reena. Are you there, sweetheart? Reena.
Yes, I'm
Right.
here.
This is for you there, and your first 2 minutes start. How many stations we have done, Pramila? I have started relying too much on you, haven't I?
This is the 5th one.
Yes, it's the 5th one.
मुझे क्लास दो ले.
Okay.
Yeah, can I start?
Yes, you can.
Hello, I'm Dr. Reena Kumari, doctor in the antenatal clinic today. May I confirm your name and age, please?
Yes, doctor. My name is Julie Hard, and I'm 32 years old.
How would you like to be addressed?
You can call me Julie.
Feel free to call me Reena. Julie, from your case notes, I can understand that this is your first pregnancy and you are 12-week pregnant, and you have a concern about some investigation.
Yeah.
Yeah. Anything else you want to add in this consultation?
My midwife asked me to have this test done, and I said I don't want to, but she then made my appointment to come and discuss with you. So
Sorry?
I don't want to have HIV test done.
Yeah. In a moment, I will come to address your concern. Can I ask you a few questions?
Yes, you can.
Yeah. Julia, is this your first pregnancy?
Yes, this is my, well, it's not my first pregnancy. I had one termination before.
Okay. May I know what was the reason for termination? Was it personal reason?
I was just too young at that stage. I was only 17.
Okay. Any problem after this termination?
No.
Okay, you recovered well. Okay, and can you tell me about this pregnancy?
Yeah, I'm 12 weeks pregnant now, and I had my scan booked for tomorrow, my first scan, and they said they're going to do some test as a part of down screening as well, which I will have tomorrow. No problems. I was just bit like I had bit morning sickness and vomiting, but that has improved quite a lot now.
Okay, did you start folic acid?
Yes, I have been taking folic acid.
Okay, so this is a planned pregnancy, right?
Yeah.
Okay.
Well, you know, it wasn't plan, but I was happy to continue.
Okay, that's very good. Julia, this pregnancy, can you tell me about your periods? Was it regular?
Yeah. They were
Okay, and this, yeah, this pregnancy is corresponding to your periods?
Yeah, my midwife told me I'm 12 weeks pregnant.
Okay, so are you updated with your smear?
Yeah.
Okay, was it normal?
Yeah, they have been normal.
Okay, can you tell me, as Julia, are you in a relationship?
Well, I'm not with living with a partner.
Okay, and so with whom you live?
I'm living with my mom.
Okay, so Saria, so Julia, have you ever been exposed to any sexually shared infection?
No, I have never
Okay.
been.
So sorry, Julia, you said you are, I mean, cannot in this partner. So since how long you were together?
Well, you know, we were still not living together anyway, to start with. But then I found, you know, we've been together for about 6 months. But recently, I found he was cheating on me, so I'm not seeing him anymore.
Okay. Do you have any health issue further following to your GP?
No,
Are you on any regular medication other than folic acid?
no, doctor.
What do you do for a living?
So I work in a furniture shop.
Okay. So do you smoke?
I do smoke, but I'm trying to reduce it. Currently, I'm smoking only like 4 to 5 cigarettes a day, but I'm working to cut it down completely.
That is very good thing. And if you want to stop the smoking, as you are trying to stop, because it is not good for your health as well as for the baby. So if you want, I can refer to your NH cigarette smoking this services. They will help you to stop the smoking.
No, that's fine. Thank you, doctor. My GP is already supporting me with that. Thank you.
Yeah, that is very good. And do you drink alcohol?
No, I'm not drinking in pregnancy.
Yeah, that's also very good. And are you using any recreational medication?
No, doctor.
Okay. Are you aware about your height weight ratio?
Yes, it's 20.
Okay. Are you aware about your blood group?
It's B positive.
Okay. So have you ever been feel down, depressed, or hopelessness?
No, not really.
Okay. Thanks for information, Julia. So come to the point, like you are refusing HIV screening. May I know the reason why you want to refuse any?
Well, I don't particularly feel I have a risk to have HIV. And secondly, I'm a bit scared, you know, to be honest, to have this test done. And that's the only reason.
May I know why you want to scare?
I mean, obviously, it would be quite a matter of anxiety to wait for the results, and then if it became positive, obviously that's going to be really, you know, I think that's going to be really horrible. So I would rather like not to know, even if I have this infection.
I can understand, Julia, your anxiety, but it is a very important to have HIV screening during pregnancy. Because if we diagnose HIV first, I want to reassure, if even we diagnose, we will keep it confidential until it affect the person. And another thing, like if any person has HIV, it is a very important to treat it because it affect on the immunity as well as it. This is an infection which can transfer to the baby, and we have the modify the antenatal care to reduce the risk to the baby.
I know about this HIV. That's what I'm scared for, doctor. You know, obviously, with HIV, you can develop AIDS and you can die. So, I mean, I would rather like not to know if, you know, that's happening rather than know about it and then keep, you know, stressing about it all the time and worrying about it.
I can understand you're worried, Julia, but you know this is an infection which affect on the immunity, and as you said, if we not treat it, it increase and it destroy the immune system, and you will get the more and more infection, and it affect on your health. So if we not treat timely, so so it will get worse.
I know that, doctor.
I can sorry.
I know that, doctor. Well, I don't want to. I mean,
So
it's not
I can
different,
see.
you know. So it's just like I'd rather not know about it.
Yeah, I can understand you are very anxious about the HIV. So may I know, Minke, do you have any mental health issue or any other problem? Or I can see you are very anxious about this problem. So do you need any counselor?
No, doctor, I don't have any mental health issues. I mean, why you think there is something wrong with my mental health for not having the test done?
No, it is your right. If you want to refuse, you have you can refuse it.
No, I found it really judgmental, doctor. I just did not like this.
No, I am not judgmental you, but I want, it is my duty to inform you about the your health concern or the health issue. So effect of this HIV on you and your baby, because if we modify the antenatal care, like with the medication
I
and
get it, doctor. It's just like the way you said, do I have some mental health problems that I'm not taking the test? I mean, that was not nice.
okay.
All right. Okay. Okay, time is over, Rina, and we stop your trouble here. Right,
Yeah,
okay.
Jennifer.
How you feel about this?
Yeah, because I don't. You were refusing. I explained to you about this HIV.
Yeah.
So
Nasty woman, isn't she? She was nasty woman. She was not actually a nasty woman. So she was doing this all because she's clearly telling you she's worried about knowing this infection, because this infection then goes to AIDS and people die with it. So I would rather not know about it, and just let it happen. This infection, what it's doing. And second point, she went upset was, and it can really penalize your whole station. I can understand, yes, you try to assess, if you're explaining, you think clearly to her why it is important, and she's still not taking it. So you just wanted to say if there is anything else going on. Is she has anxiety and all that stuff or whatever?
yeah, that's why.
But you need to do that in a very sensitive manner. If you will take it immediately when she says you're not having the test, and then you relay, do you have any mental health
Yeah, I
issues?
should say that I should say here. Whatever I discuss, I will keep them confidential. So after that, she
Well,
may tell me.
no, that's fine. The confidentiality is different thing. The point here was of becoming judgmental. That she's refusing the test, and it's not like, why it's very judgmental, and it's not nice. I didn't find it nice that you're saying I'm refusing. If I'm refusing the test, I have some mental health issues, right? So we won't say that way to the woman. And even when we are doing their mental health assessment, we don't basically use the word by saying, do you have any mental health issues? That's why I feel like, are there any concerns? Anyway, let me
No,
just.
but when I said you have you feel down, depressed, anxious, or age, she said no, I am not.
Yeah,
Then she
that's
was continuously, despite my counseling, she's refusing. Then I said directly,
yeah,
do you have a
yeah. And that's what she will find. She will react very badly.
judgmental?
That's right. That becomes very judgmental. And obviously that's fatal mistake. Okay, so basically, again, when you read the scenarios at the cubicle, obviously you need to think, okay, this woman is not wanting to have the HIV screening. Then your first bullet point will be to write down, to plan your answer. I need to explore the concerns why this woman doesn't want to have the HIV screening, and then obviously address and satisfy and answer her concerns accordingly. Second thing I will be thinking about, it is very likely reason people don't want to have the test for two reasons. Number one, they find it very difficult when they're waiting for the results. They think they cannot handle that anxiety. Okay, so that's one question. And I did say that as well, like that, it would be horrible to wait for the result to come down. And the third point is the people feel, just like as in old days, if you're diagnosed with HIV, there isn't much which can be done basically. You're going to develop AIDS and then you're going to die. And for that reason, the feeling is if nothing can be done, or still we are going to have a really bad and poor outcome, then why to know? And just destroy your life, whatever's left behind as well. Keep worrying about it. Okay, if it happens, then I will get ill and then I will die. That's okay. That will be done. So on these three main reasons, then we need to basically address what her concern is. And sometimes they have a fear, they don't want to know it because then they feel they can't tell it to certain people around them. It can maybe their partner, it may be their employer. They feel if they did the test and they told them, then they maybe break a relationship, but they may lose the job. These are 4 or 5 different common reasons why people do not want to have HIV testing done. Okay, so coming back to this particular woman, she said she was the number one. I felt you took quite long to take the history. By the time you started counseling, there were only hardly 3 minutes left. So again, history taking and information gathering, try to make it according to your scenario. We know in this particular scenario, there is a lot of counseling we need to do. There is a lot of information we need to give her. I'm going to really save my time on information gathering. So my first question from her will be, I can see you're 12 weeks pregnant, but you do not want to have a HIV testing done. And then you can just start by saying, so are there any particular concerns you would like to discuss with me? For which reasons you don't want to have the test done. Okay, so I will just start basically from there, and then I will gather the information as I go along. So let her open up and say what she says. Yes, and that's a natural way to start as well. What are your concerns? Yeah. And then she opens up and say, well, you know, I don't want to be, it will be really scary to be waiting for the result. And then, you know, if it states, then the first thing, just small answer to take her anxiety away. Okay, so yes, I can see. It can be quite stressful when you have the test done and waiting for the results. However, we do have one very quick and rapid test available as well. So what we can do in that test, we can just do a fingerprint facial test and check here in the clinic. And that test result will be available within 20 minutes. All right. However, we will still need to do proper test from the laboratory for you know, confirmation. But you know, you will know about the result within 20 minutes. We'll have some idea about it. So that will help her to. Then you can say, do you feel this may help to remove your anxiety? That anxiety related to waiting for results. Okay, so that's the first thing to do. Second thing, when if she says, and she said as well, well, I would rather not know because of the AIDS and all that stuff, then you will say, yes, that is another common concern. So first I can acknowledge and normalize it for her that this is not unusual. It is common for people to feel that way still, that HIV infection is very serious infection and nothing much can be done if you're diagnosed, and you know, it's going to lead to AIDS and to the death. But that's not the case now. With all the modern medication we have, HIV is quite easily treatable and controllable disease. Okay, yes, it is not completely curable, but these days it's just like we can manage and keep HIV under control, just like high blood pressure or diabetes. The people who are diagnosed with HIV, and again, I'm not so going to say if you have diagnosed, you will take the medicine. No, I'm just again trying to keep it, non-referenced. So the people who have HIV infection these days, they obviously, yes, they need to take the medication, and the medication has become very simple as well these days. We can actually manage this infection even with one single tablet in a day, and the people live normal life, normal expectancy of life, and health-wise as well. The people around them even doesn't know they are suffering with this disease. Okay, but obviously, yes, it is important that this infection get diagnosed earlier, treatment gets started earlier, and the patient then follow, you know, all their follow-up appointments, and then they have the normal expectancy of life and everything going on normal. But at the other side, if obviously it's not diagnosed early, then obviously it's going to, progress. Then it's going to cause a lot of damage to the body's protection system, or the immune system, we call it. And as a result, then the person will, by the time the person will start showing any symptoms because of different infections, or even that can increase the risk of getting certain cancers, then it will be too late, because the disease would have spread already too much and would have caused that damage, which will be irreversible. And then, yes, it will develop into AIDS, and then even it can lead to death. So for that reason, that the testing is so easy these days, and because it's easily treatable and controllable, we routinely offer all our pregnant women to get that test done. Because if anybody is diagnosed with that one, then we can start them on medication, and we can reduce the risk of transmission that infection to their baby, because HIV can be transmitted to the baby through the womb. And obviously, you know, that baby will have to then live the whole life. On the other hand, we do have, you know, those simple medications available now, which mother can take and keep her disease under control, as well as can save transmitting that infection to the baby. Yeah. So once I do that, you can see now this woman should be happily, you know, her concerns are gone. And then she knows as well, now I have given her basically responsibility that if you don't do, in indirect words, obviously, if you don't get tested and you have the infection, you're going to give that infection to your baby, and then that poor baby will have to live with that whole life. On the other hand, it's so easy, you know, we can just control it with simple medication, and your baby will be fine, you will be fine. Yeah, so that will make sense to her. No, it's sometimes if they say there's, I think there was another scenario in which this woman, the reason of her not having testing is she says she doesn't want her employer to know, and she's working in some care home or whatever. In that case, if that's the reason, then you need to tell them by saying that, you know, if your infection, even if you are positive for HIV, you don't need to inform your employer. You don't need to inform your employer even about that you had a test, because the nature of your job does not put the people who you work with at any risk of getting that infection from you. The way this infection is transmitted from one person to other is through the through sexual contact. It's through the secretions, so through sexual contact, or through the blood transfusion, or through some needle prick injury, which is contaminated with the blood with some HIV positive. So then, depending upon the job, obviously you can think about it's only the surgeons maybe, or those people who can, and then even you can say that even in those cases. So I mean, don't go into details. If she's not surgeon particularly, don't go into that stage. Just simply say, and because your nature of job, it doesn't put your the clients at risk, you don't even need to disclose. Even if it come back positive, you don't need to disclose it to your employer. Regarding if they say friends and family, they will know, and then I will be worried about passing on to them. The same way you can say then as well, this is not the infection which you can pass just by sharing your eating together, sharing, meeting your friends, or even kissing. This is not the way. Yes, the only person who can be a risk is obviously the sexual partner and the children, if of an infected mother, the children who still are to be born, are you carrying in the pregnancy. All right, so this is how you will explain. Then the history taking, I will keep very limited history about her. We're saying, okay, is that your first pregnancy? Then she reveals and says, I have one termination before. Yes, you can just quickly ask about, what was the reason for that termination. If she says, oh, just young, that's why I have, that's fine. That's okay. And then you go ahead with the partner details. Now, what else is important here? The very important thing here is to do her assessment for HIV, risk assessment for HIV. Because if, in spite of me giving her all this information, she still doesn't want to go ahead with the test. And if I have done the risk assessment for HIV testing and that she's low risk, then I wouldn't be too much worried about. I will still keep the option open to say, you can. It will be a good idea really to do that and exclude and have a peace of mind. So you can actually, if you change your mind later on in your pregnancy at any stage, you can come back and we will do that test for you. However, if when I do the risk assessment and she's found to have some clear risk about the HIV infection, then I'm going to clearly tell her that because of this and this reason, your risk of having this infection is slightly higher than the average any other pregnant woman. So it would be a really good idea for you to get tested, and then if it is, it's easy to treat and you can prevent that infection passing on to baby. Okay, so then I will stress maybe a little bit more on that woman. So what are the risk assessment? What we do the risk assessment, how far? So that starts you from, so before I do the risk assessment, I will say, so also to get an idea about, when I said, well, I don't feel I'm at particularly at risk of getting this infection anyway, yeah? So no, she feels, is she aware of what are the risk factors, right? So what I'm going to do, I will say to her, okay, so let me ask you if you don't mind, I would like to ask you a few questions regarding your sexual and social lifestyle to get an idea about, to assess your risk of having this infection. Is that okay with you? Make sure you have taken the permission. And once she said, yeah, that's okay. After that, don't worry about asking the questions. Just ask them very clear, open questions. And the first one will be about the partner. Okay, so about the partner is, so your current partner, how long have you been with this partner? All right, and do you have sexual contact? So say she is still in a relationship, she says I'm with this partner about last six months or something, then the next question can be, have you been ever tested for HIV till so far? Has your partner been tested for HIV? Do you have sexual contact with anybody else other than your regular partner? All right, and what is the region, which country is your partner from? Okay, which country your partner is born? And at the same time, you can explain, because in certain parts of the world, the HIV infection is more common as compared to others, and that's why I'm asking this question. She doesn't ask, yeah, so which country your partner was born? And then the next question will be to ask about, do you use any drugs through needles, right? Not only simple recreational drugs, just clearly ask, do you use any drugs through needles? Does your partner use any? Do you have sexual contact with anybody who use drugs through needles, right? Have you ever had any blood transfusions? Have you had any dental treatments, blood transfusions, or any operations outside this country? Yeah. Have you ever paid or been paid for sex? Yeah, so there's commercial sex worker risk. Have you ever had sexual contact with a man who might be having sex with other men? Do you ever have sexual contact with somebody who's diagnosed with HIV or hepatitis? All right, so these are must ask questions for HIV risk assessment. All right, so you all can make a note of this. So this must be done. There will be marks for it. Okay, so if you don't ask these questions, you're going to lose those marks. All right. So if the answer is no to all, and then you have explained the way I have told you already, then this woman, you can say yes from the details you have, information you have given. You seem to be quite low risk to have this infection, but still these days, we do offer that too, and we encourage that this test to be done because it's easy to do. This test is easy to do, and then if somebody is with the infection, it's easy to treat. So how you feel about it? So again, and then I'm going to ask her. If she says yes, I will think about it. If she says I'm happy to go ahead, that's fine. You can say okay. So I make the arrangements for you to your test to be done. So we can do that one finger prick test here in the clinic, and result will be within 20 minutes. Would you like me to do that test for you? Okay, so must check that as well, because sometimes if they're alone, they don't want to do that test. They want their partner or somebody to be with you. Again, even the 20 minutes can be quite stressful for them. So just check. Otherwise, you can say, so we will also do a blood test. We must do the blood test anyway, proper venous blood, yeah? We'll send that test to the laboratory. And then we will let you know about the test. If she says, no, I don't want to, or I will think about it, you can say that's absolutely okay. You can have a think about it. I will give you some written information about this test, about the infection HIV and the treatments available as well. And if you change your mind and you would like to go ahead with the test, you can just let your midwife know and we will arrange that test for you. There is no, obviously, the time restriction. When there's no time when we can say you can't have this test. This is for you guys, not to say the patient. This is for you guys. I mean, there is no, sometimes girls ask what is the latest limit in pregnancy we can do HIV test. It can be done at any time whenever they're ready. So yeah, so that's how you will conclude this station. So regarding the partner, she said he was cheating on me. And as we know, that's why we are not living now together, and I'm not living with him. We just in the last station we said as well, if the partner is not with them, please make a habit to ask just one question to say, if you don't mind asking me, let me know, was there any abuse involved in the relationship at all, or do you have any concerns, any ongoing concerns of safety or anything else from your that partner? Okay, quick question before we take a break.
When she said she was not living with a partner, should we also ask, are you happy to continue the pregnancy? Meaning after asking all that history about abuse.
Yeah. So she said about the pregnancy, because you did ask that question in the beginning, Reena, when you said like, she said like, is it planned pregnancy? So the answer was, well, it wasn't planned, but I'm happy to continue with our pregnancy. Okay.
Okay.
Doctor, when she is a primigravida, do we have to ask any previous pregnancies?
With these type of scenarios, sometimes when there is something not quite straightforward like this one, it's okay to ask, is it your first pregnancy? Otherwise, yes, if it's given primigravida, don't worry about asking any other pregnancy.
Doctor, how to counsel if they have a needle phobia?
Sorry, how to do what?
How to counsel the patient if they have needle phobia?
If they have a needle phobia, okay. So again, first of all, acknowledge. Must acknowledge and say, as I can say, it can be quite, it can be quite terrifying for some people to have the test taken because they don't like the scene of the needles. However, there are different ways we can do. Now, some people, and it's quite ironic though. The most of these people who have a needle phobia, they have the phobia of proper test being taken. They're okay with the finger prick, although I personally find finger prick more painful than a venipuncture. But anyway, so that's was one thing to say we can do, and you you don't need to even look when we're doing it. Number one. Second is then offer them to apply the lidocaine gel first. So we put that, we call it amla cream, but it's actually lidocaine. So you can say we can put some local anesthetic on that surface to make your skin go numb. And after a few minutes, then we will take that several minutes. Very quick test. You can have some family member, friend, or whoever partner, whoever with you to hold hand and have the spot. And if not, then obviously finger break. And if they still say, well, no, all of these things are wrong, then obviously you can't do anything. You just have to just make them aware to say, okay, well, then you obviously can't do anything. I hope they won't be making that reason that I'm neighbor phobic. But if she is, then obviously you can apply. You can say, knowledge and say, we'll apply this local aesthetic, and you can have just
Ma'am, suppose she is not willing to do the testing. So basically, we will consider her as positive. So after delivery, what about breastfeeding for such a lady if she has not done the testing?
No, Pramila, let's stop here. No, if she's not willing, we're not considering her as a positive. Not at all. If she is not willing to get tested, and if somebody is not tested, they are considered to be negative. Right? Simple.
Okay.
You don't need to do anything extra with them. Yes. If she give me some very clear risk factors, which can be like as strong risk factor that the partner is for HIV. Okay, then yes,
But
my
Dr.
approach.
We already discussed this thing in the last session, I think, last course, that if anybody who is refusing continuously and will come in labor in like an emergency, so we will take her as a positive because we don't know her status.
No, Sajila, no, I never discussed that. Never in any course I never said that. Because we don't do this
But
way.
if the patient come in the labor,
So, okay. This is, I don't know how I understood like that if somebody is continuously refusing.
No, I never did. And this sexual health, and this one is my special interest modality anyway. So you can trust on me inside out on this particular topic. I never told that. I do know most of my trainees do bring this thing here because it has been preached in some other courses by some other mentors. No, that's not. The only one scenario where I might talk differently to the women is if the partner is HIV positive and she's refusing to have the testing done, then we know there is a very strong high risk this woman is likely to be positive. Then I might go into that discussion by saying, first I will very clearly tell her that I'm going to clearly say her, I'm not going to even use the word risk. I will ask them, even, okay, so no, because you have gone into extended discussion to remove your all these confusions. Even the people who have HIV positive partner, we put them on pre-prophylaxis these days now, okay? HIV pre-exposure prophylaxis, all right? So those women basically are on those pre-exposure prophylaxis, and then they can have, obviously they need to have unprotected sex to get pregnant, all right? In the days before, there was no pre-exposure prophylaxis routinely available. There used to be, the partner is on treatment and their viral load become undetectable. Then those days, then we will ask them to do unprotected sex, or then we were doing semen collection and doing the sperm wash. But that's not the scenario now these days. No, routinely here, the pre-exposure prophylaxis for HIV is available. And almost now all the partners of HIV people and the people who are at high risk, like who are involved in high risk behavior, like MSM, almost all of them are on pre-exposure prophylaxis. They take just like a contraceptive pill every day, okay? So if somebody is like that, then even the partner is positive and she's negative, even then I'm going to do the risk assessment. So I will ask her, is your partner on the regular treatment? Okay, first obviously I'm going to encourage her stronger in clear words to say, if your partner is positive, then have you had any tests done till so far though? Let's check first. Yeah, if she has never done, then I will say, well, you are highly likely to have the infection. However, let me ask you a few questions. So then ask how long she's been with this partner. is the partner on the treatment for HIV? And if the partner is a treated me, do you know anything about his viral load? Did you tell his viral load is undetectable? Okay. So if somebody's partner is, she has just recently met the partner, maybe the partner is diagnosed for maybe 3 years, but she's with him for 6 months only, and the partner is taking HIV medication and his viral load was negative, and they did only, few certain days of unprotected tests, she still can be at low risk. Otherwise, she is using condoms all the time. Then she still is low risk to have HIV. But yes, in that woman, we kept her insisting and encouraging to have the test done at this stage, and every appointment we will be encouraging her to have the test done. But if she doesn't want to go for the test, we will not do anything different for her during her labor. We're not going to give her anything like that. We might discuss with her about that pre-exposure prophylaxis, though, that if you're not already on that prophylaxis, you can start now. And then what I'm telling her, though, however, when you deliver, then the baby will be tested for that infection straight away. Okay.
Yeah.
And then we will be giving post-exposure prophylaxis to the baby. But you, in obs and gynae, you won't be actually put to these type of complex HIV management scenarios. Don't worry about that and don't confuse yourselves at all. And please, in last 6 weeks, please, all of you, strictly, just stick to my recordings, please. Okay.
Yeah, we are doing it.
It's fine. Now you've got Sajila. It's fine. Obviously, there is so much to learn. Obviously, it's okay for you guys to. I'm not saying don't listen to others. Listen to others, but just for the factual correction, last 6 weeks must stick to these recordings. So when you appear at the exam, you don't get confused with anything. Okay.
Okay. Thank you.
Dr. Safia, one last question. How long does it take for the result to come, HIV result? Because the patient is ready.
So the one rapid test which I said by needle prick test that is done in the clinic, and just like as we're doing this lateral test for COVID or pregnancy test, basically that type of kit. So that result gets ready within 20 minutes. The lab test is also available these days now within 24 hours.
Okay. Sure. Thanks.
24 to
Hello, ma'am, one question, ma'am. If the patient says she's a commercial sex worker, is there anything else extra we have to do during antenatal care, ma'am?
There will be a lot extra to be done for commercial sex worker if she is, because first of all, we need to obviously then do the risk assessment on her, which obviously she's high risk if she's having unprotected. Again, these commercial sex workers, they again here in this country, basically, because it's not something which they need to hide or kind of thing. So they basically, most of them do come for the regular checkups for HIV and all that screening. That is actually part of their job. They need to show it, to the clients, or if they're working through the companies, that they are actually regularly getting checked. And then they're having protected sex, like they're using condoms. So just being again commercial sex worker doesn't necessarily mean she might be on pre-exposure prophylaxis. That these days, that pre-exposure prophylaxis, basically for you guys who don't know that, means they are taking the medication, which is called, one of the medicines that's called tenofovir, Truvada we call it. That's just one tablet they need to take, just like that. Well, that's quite a big tablet, not like a contraceptive pill, but just like that, one tablet every day they keep taking. And even if some infection is transmitted to them, obviously that won't develop in their body. Okay, so this pre-exposure prophylaxis of HIV has entirely changed the scene of HIV infection now these days. It's not long ago. It's just been started from last 1 year. We have started, it's been on NHS now, provided to all high-risk people. So these commercial sex workers who actually are doing, any that type of sexual activity they're engaged, they might be on that one. So we need to then talk about that and all that. So we can do that as a whole station at some stage. If you guys think that I haven't heard any scenario as a part of recalls. But if you want to, I can put into slide and we can discuss that. Somebody who is using drugs or who doing, like, how we need monitor their pregnancy. Okay.
Ma'am, last question. Ma'am, can we ask directly them ever been paid for sex in the history?
Yes.
We can ask.
Yes, so before that though, if you when you will listen this recording, you will listen that before I actually prepared her, yeah, I said to her to do the or know the risk of your HIV infection, or to do the risk assessment of your risk for this HIV. I would like to ask you few questions regarding your sexual and social lifestyle. Will that be okay with you? And when she says yes, it is okay, that means these are the and then again these questions, they are not people are familiar with it now. People are coming to sexual health services as a routine checkup. Young people 14 15 years old who have engaged themselves in sexual activities, they are coming and having all these HIV tests, and they are used of listening these and answering these questions. Okay, so don't worry about it. Say rare case scenario, if somebody goes upset and say, well, no, doctor, why you feel I would have been doing this? I mean, I wouldn't ask you to do this as a part of your rest of the antenatal care. Obviously, this will be only for sexual health screening, really, or assessment of HIV. You should ask this particular one question, paid or being paid by test. But otherwise, if you ask, nobody will mind. And if they mind, then you just simply say, I'm sorry that you found it, this way. You found it, you don't like this particular question. However, we routinely ask these questions to everybody who attend this service as a part of their risk assessment for HIV infection. They will be fine. So before sexual history and use of drugs and all that, you do just say one statement. I would like to ask you a few questions regarding your social and sexual lifestyle, and that should be fine. After that, you can ask very straight, open, quick questions. That's all. We're gonna take a break now, and then we'll be doing the rest 5 questions after. So we're gonna take break only for about kind of 15 minutes. So I will be back at 4. So you all can be accordingly. Okay. Okay, who is next?
Anilasri.
This is your Anila. Okay, that's for first 2 minutes.
Hello, I'm Dr. Anila, one of the doctors in the clinic today. Can I confirm your name and age, please?
Yes, my name is Catherine Whitehead, and I'm 32 years old.
How old are you?
32 years, doctor.
32. Good.
Yeah.
How can I address you?
You can call me Cat.
Kat. Kat, I think you have done your scan today and you have been waiting for the reports. Is it so?
Yeah. So I'm carrying twins, doctor. So I'm having these scans done like after every 2 weeks. And I am aware that my one baby is growing smaller than the other one, so that's why they're doing fertility scans. But today, after the scan, they wanted me to wait for you to come and talk something about the scans. I'm really anxious.
Ma'am, I'm not able to. There's a, disturbance in your voice, ma'am.
Okay.
Hello.
Hi. Is it for everybody or is just yours?
Even I can't hear you properly, doctor.
Okay. Let me just see that. Is it better now?
Yes, ma'am.
Right. Okay. Yes. Yeah. So
Are you aware of the scan report, Kat?
No, they haven't told me today. They said the doctor will discuss with you. So I'm really worried about, are my babies okay? I'm really anxious.
Yeah, I understand that. You must be aware that your babies are sharing a common afterbirth, and but they are in a separate bags of this one. Are you aware of it, Kat?
Yes, doctor. I know I'm carrying twins, and yes, they're sharing their
What we
blood.
call it as a this what we call it as a monochorionic diamniotic twins.
Yeah.
Uh, do you have somebody else with you, Kat?
No, my partner is not here, doctor. So I'm okay. You can discuss the report with me.
Yeah. Because the report today I'm discussing and management further what is possible for us will be a little elaborate and also a lot of information I would be sharing. So please ask me if you have any doubt in between.
Okay.
Okay. Kat, you know that you have two babies. One baby, we'll address them as baby one and baby two.
Okay.
If we take the scan report, the first baby growth is not up to the what we are expecting. It is given as fifth percentile, which means that your baby is the of the lowest weights. It is among the five. If you take 100 babies, it is among the lowest five babies. This one. This is because there is also concern regarding the blood flow to your first baby.
Yes, I am aware of that. Yeah.
Okay. Whereas the second baby, we see that the growth of the first baby, at the expense of the first baby, the second baby is growing much larger compared to the what is expected. That is in the 90th percentile, but the blood flow as of now is normal for the second twin.
Okay. Yeah.
Okay. If we see that the first baby growth is affected and blood flow is also affected, so there
Yeah.
is always a chance that this baby can die sometime in utero if we delay
Oh.
the delivery.
Okay. Right. Okay. So
But
do we need to deliver them now then?
yeah, let me say you but some women would prefer to wait for because now you are only 27 completed weeks. You are in the 28th week. The baby's maturity will not be as good as when you deliver little later.
Okay.
That is, they may need for the breathing support. They may need to stay in the NICU, and also, I mean, the baby special will be under the baby special care units, and sometimes even during and we do not know how their long term this one is going to be their effect is going to be after the delivery.
Okay.
So another option is some women would like to compromise the first baby and wait for the second baby to mature and deliver little later.
I can't. How? I mean, doctor, you said like if we left the
Yeah,
baby can
the
die. So
yeah, we generally refer you to the fetal medicine unit. That is who take care of this special type of pregnancies. Specialist doctors who are more interested in looking after this, who are more specialized in looking after this type of pregnancies, and they will discuss you what are the options that are available for you, and also uh, even the baby doctor would come and address what are the how the babies are to be looked after if they deliver at this stage.
okay.
Whereas if you take the other option, what I was saying is you have to compromise the first baby in the sense we need to we will not monitor much above the first baby. There can be death of the baby inside the womb because of the no blood supply.
That's such a difficult situation. No, doctor, I don't want to, let my baby die. I would like to give both babies equal opportunity, the same chances to live. So I would rather like you guys to deliver me.
Okay, I understand the news must be very disturbing for you, Kat. Uh, if you are willing to go with the delivery, I would refer you now to the fetal medicine specialist, what I have said, and then you will be from there you will be monitored by them, and they will also give some steroid injection which will improve the which will help in improving the breathing of the baby once they are born, which will be given over 24 hours. And also they would like to give even a medicine called as magnesium sulfate, which will help in protecting the brain and improving the capacity of the brain once a baby is born.
Okay. Okay,
They
doctor.
will, yeah, they will be waiting for your concern for the delivery, and also the baby doctor will come and discuss with you how they are going to look after the baby and what are the problems the babies can face during this period of post delivery, all these things, Kat.
Okay, doctor. Yeah.
Okay.
So when you will deliver my babies then?
Yeah, now as now there is always already a blood flow is not good in your first baby. We just want to see this is only one blood vessel which is being seen. We what we call as an umbilical artery. We can see the what is called as ductus venosus and another blood vessel.
Yeah.
Can we wait for another 24 hours or not? We will be knowing, because we want the steroid to work before the baby is delivered.
Right. Okay. Okay.
Uh, so I'll be referring you immediately to a fetal medicine specialist. They will be arranging a scan and they will be looking after uh, further management. I will discuss this even with my consultant and let you know. I'll give you the written information about this.
Okay, doctor. Yeah. Yeah.
Any other concerns, Kath?
I just, I want to just know as well, like, will these babies require any, any treatments when they deliver, particularly the small baby?
That will be discussed with you by the baby doctor, Kath.
Okay. Okay. Yeah, that's okay. Your time is over, but you can add if there is anything else you think you would like to add up.
Nothing comes to mind.
Okay, that's fine. You were pretty good. Right. Okay. So, no, this can be quite difficult situation in a way that it involves quite difficult conversation, and there will be a lot of empathy factor of your communication skills to be assessed here. And then how you approach, how you give this information to help the women to make an fully informed decision. So to start with this scenario, a few factual corrections. We won't be referring this woman at this stage to fetal-maternal medicine. Yeah. Hello, am I audible?
Yeah. They will be
Yeah.
already under fetal
Yeah.
medicine.
Yeah. So basically, obviously, these twins, with twin-to-twin syndrome, they will be, referred to and been looked after by the fetal medicine, and not by the fetal medicine specialist only. They will be looked after in tertiary care hospital, just because of the procedures or the interventions they require. So if it happens to be, then you need to assume actually your unit is the tertiary care hospital unit, and you have the fetal maternal medicine team with you, and you have all those facilities as well to look after these babies. But you can still, for the examination point of view, for your examiner to register and mark you for that one, you can still talk about fetal maternal medicine, which I will tell you in a minute how to do this. So this woman, after an introduction, you're going to first assess her pre-knowledge, because otherwise there will be too much to talk and give her information. So I will ask her by saying, Kathy, I understand you are 27 weeks and 5 days and you're carrying the twins. So do you want to tell me, please, what you understand till so far about your pregnancy? Okay, so just encourage her to, she tells you, because then you may not need to explain a lot of things. So obviously by this time she should know, and she will volunteer the information. I'm carrying 2 babies and they're sharing after birth, and their blood is also shared. And then you can say, you can also ask her, okay, so you've been having these also, establish whether she had some treatment done for that already. Yeah, because if you wanted to do any coagulation or any laser treatment, this would have been done from 16 to about 26 weeks. Yeah. So first thing you can ask her, you say, so I understand you are booked, your care is booked with one of our fetal-maternal specialist doctors, we call them. So let her confirm and say yes. And then the next thing you need to tell is to say to her is that, I will let your, consultant know as well that you are here today because of, some concerns in the scans of the baby. And then you can just give her information about the report first, because she's anxious. So before I take any history, all I need to know at this stage is what she understands from MCDA and twin-to-twin syndrome, and whether she had any treatment done before, and if that was, not successful. After that, and establishing fetal maternal medicine, I'm just going to explain, and I will say, right, okay, so you've been having these frequent scans for the babies because one baby is growing smaller. The baby 1 is growing smaller as compared to baby 2 because the baby 2 is getting the largest share of the blood flow. That is affecting the growth of the second baby 1. And that's why the baby is small. The scan today, after the scan today, we do have some concerns about the well-being of the baby 1. So I'm afraid I will be taking some difficult conversation with you. Would you like to call your partner with you as well? Or any family member or family friends, yeah, with you before we discuss this in details. So a bit complex and bit difficult conversation. This is how you can say, a bit complex and bit difficult conversation. And then you can start telling about the scans. You say, so, as you understand, baby 1 is growing smaller. So the baby's, the growth is actually gone below you, 5th centile, 90th centile. Patients don't quite clearly understand, or if she would have been told about that as well. So you can just say, the baby is growing, towards much smaller size, to the extent where we are worried about the baby well-being. And then the scan for the blood flow to the baby shows that the blood flow to the baby is seriously compromised. And as a result, this baby can be at risk of dying if not delivered immediately. Okay, so this is you're going to explain. Baby 2 is growing, as you understand, it's slightly towards larger size. However, the blood flow to the baby and the water around the baby, that all is normal. So there is no concerns about the well-being of the baby 2. Okay. And then you will say, no, before I actually discuss in details how we can manage your pregnancy, how we can manage the situation, I need to get some information from you. And the information will be obviously just those standard questions. Do you have any other problem in this pregnancy so far, other than obviously that your babies are twins and they're sharing the blood flow? Any other problems like hyperpressure, diabetes, or any other concerns? Was the 20-week scan of the both babies reported as a normal? Has there been any other concerns about the baby's well-being before this particular scan?
And then you can ask if it's not given, she's primary gravid or whatever, you can ask, is this your first pregnancy? If she has any pregnancy before, just that standard question, any problems in that pregnancy during delivery or after, routine thing, BMI, those 3 questions, our favorite ones, any history of blood clots in legs and lungs in yourself or in the family. And have you been recently feeling low in mood, depressed at all? Acknowledge, I can understand this whole situation is quite stressful for you. You know, so what sport have you got? Now here by sport, we not only means by the partner, we means what other sport, like from family and friends she has. And then you can particularly ask about the partner as well. Do you feel your partner is quite sportive and you feel happy and safe with him? And then you will say, then you will say, okay, so coming to the scan today, you know, as I like the baby one, we will need to deliver the baby, otherwise this baby can die. However, as you know, you're only 27 weeks and 5 days, so these babies are very premature. So these babies' lung function, their brain development still is not, you know, quite mature to the level where babies can actually survive after delivery without any problems. Okay, so these babies, if they are delivered at this stage, they will need to be kept or looked after into intensive care unit of the babies for a few weeks. Because these babies can be at risk of serious infections. These babies will be at risk of serious risk of breathing difficulties, which can, you know, sometimes even lead to death. However, we will be providing all that support to the baby by keeping them in, you know, controlled environment, giving them oxygen, and providing all the support. But still, there is a small chance that the babies who are born at such an early stage, they can die because of infection or respiratory difficulties. These babies can have long-term effects on their physical growth as well as on their mental growth. So these babies can have you know, different range, you know, ranging from mild to quite serious learning difficulties as well. So if we are asking about the delivery, we're giving that option, we need to clearly tell her what will be the long-term and the short-term consequences of that, right? And that's why we prepare her by saying, I'm afraid I have to take some very, you know, complex and difficult conversation with you. So these are the signs, and but at the same time, we are reassured as well what we're going to do. Yeah, we will be keeping this baby, we will be providing the support, and we will be doing this all. So, and then you can say, so due to these all complications and risks, some couple or some women who have faced a similar situation or the same circumstances as you, they may choose to give, you know, maximum chances of further development to the healthy baby. Because at this stage, if pregnancy can be prolonged even for a few days, that is significantly going to increase the chances of the survival of the babies, and also for the, you know, overall mental development and the physical development of the baby. However, choosing that option means the baby one can die at any stage. And then we cannot 100% promise that we will be still able to, you know, lengthen this pregnancy for a more desirable time period as we like. Sometimes if that happens, you may just go into labor, spontaneous labor yourself as well. So, and obviously just monitor her reactions. She obviously get, this is going to be quite terrifying, quite stressful, quite difficult situation. So you need to acknowledge to say, you know, I can see this is a certainly distressing situation for you, and then offer as well if she's very upset, although in the beginning you offer to call the partner, again you can at some stage offer, would you like me to call your partner or somebody here for you, because this, I think this type of situation and decision taking is even more difficult than, you know, cancer and those type of things, like where you're thinking about trying to save one baby on the expense of other or just lose both of them. So you will explain that one, and then you need to continue with that as well. Like if that happened, what happens? So once we told her like it may not still be necessary to that we able to buy more days, you may go into spontaneous labor yourself, and if the baby won't die inside, or we may have to selectively actually stop the blood flow to that baby to break that connection between, because if one baby dies, then there can be some harmful toxins can be transferred to the other baby, they can harm the baby. So we may actually need to stop that connection as well. And then the second baby's brain development can have some effect from the death of first baby. So we will be monitoring that baby with a specialist scan for the brain development, particularly with the help of special scan, we call it MRI. And after that, then you will ask her how you feel about this. What would you like us to do? Right. So at this stage, it's important that we take her now if she knows what she wants to do, so that we then go into more detail about that one. How are we going to monitor if we are going to continue with the pregnancy, or how are we going to arrange for a twin preterm delivery if she chooses for the preterm delivery. So there can be two possible options obviously here. One can be she may come up with a very clear decision, which is most of the time is they like to go obviously for birth for both babies. Obviously, there is some chance she might choose the other one, or she might just simply say, well, I don't really know what to do. It's so shocking for me at the moment. So if that's the option, then simple, you can say, okay, so that's not a problem. I'm going to give you some written information here with this situation. And then as soon as your partner is here, if you want to discuss with him, then, we will make arrangements accordingly. However, it's very important that you discuss with your partner and take this decision pretty soon. Meanwhile, what I'm going to do, I'm going to put the monitoring for the continuous heart tracing of both the babies, and I'm also going to request one more specialist scan for further to assess the further well-being in the blood flow to the baby one, and that one we called that's the blood flow to the brain and particular blood flow through the heart of the baby. We called it middle cerebral artery ductus venosus. So this is all like in simple words first, and then so this is what we call them. So the examiner can mark you, yes, this is what you exactly mean, these ones, and then we start SAT, this. And then what we will try to do, if you want it, or if she says clearly, yes, I want to, deliver them, then you will say, okay, I'm going to do this monitoring and this one, because we would like to buy some time and few more hours to try to give you some steroids to help baby's lungs to get mature, so that the risk of breathing difficulty can be reduced once they are born. Okay, so we would like to give you 2 injections, and then we can tell like they will be giving you 12 hours and 24 hours apart. We will also start you on a medicine through the drip, if that's okay with you. We call it magnesium sulfate, and that will help to baby's brain to get mature, and that will reduce the risk of having learning difficulties in the babies. However, we may not be completely able to prevent it from happening. So I need to now then immediately I need to check with our baby doctors and the baby unit to make sure that we do have 2 cots available. It's very important to say even during the counseling, okay? Because you keep doing all that stuff and then you don't have the cots, okay? This is safety point as well, and obviously there is marks for that as well. I'm going to check that. I'm going to discuss with my consultant, inform, and then I'm going to contact your consultant as well, our fetal maternal specialist doctors, to inform that you are here and this is the scan report and this is the plan we have discussed with you. All right. And yeah, and then accordingly you will say, do you have any questions? I'm going to request baby doctors to come and speak to you as well, so they can also discuss and explain you in more detail about the baby's, well-being in both cases, in both options, how that will be done and how that will be monitored. Okay, we will be delivering you by cesarean section. And the babies will then stay in the baby unit for a few weeks. Highly likely they will stay there for a few weeks before they can be brought back to you and you can take them home. So this is about how you will be talking about this station. Obviously, invite any questions. Make sure you respond to her emotional response, okay? It may not be as important to complete this station. More important will be actually to respond to her emotions as well, what she's doing, how she's reacting, okay? Taking pause, giving her time, checking with her if she is very upset, visibly upset, then giving her scan to say, giving time to, would you like me to continue or would rather like me to just, give you some time. They're definitely going to ask you after that, no, tell me more about it, but it's important to check. So Sapna is asking question, who does follow-up scans for MCDA twins, fetal maternal unit specialist or sonologist? These scans are done, the sonologists, the routine sonographers don't do these scans. They are done by fetal maternal consultants. Quick question,
So,
please.
yeah, Dr. Safia, so here there is no time to take the other history. Just like, do we have to get a basic history of ops history and medical and surgical and BMI, everything?
I wouldn't
Because
worry about the BMI I will ask. So we did ask. So those 3 questions we must ask anyway. BMI, domestic, and that
we
one.
feel,
And then we did say if she has any
okay.
pregnancy, you can just briefly ask, is there any pregnancy? I wouldn't go about the, those smears and periods and those type of things. No. And other complications I have told as well. So when you will re-listen this recording, you will be able to just formulate what we need to ask and how much. But again, yes, it's very important for you guys when you read the question before you start to get an idea to yourself, what is the main chunk of this station going to be? So main part of this consultation is going to be towards counseling. Okay, so your time for information gathering or his history taking should be comparatively less, and among that as well, your more time should go about asking her, getting this information, how much she understands for her condition, what has been done till so far. That is also part of your information gathering. Okay, so information gathering, when it says down there information gathering, you will be marked for this and this. Information gathering does not necessarily mean the typical full history form template. No, that is everything, including her understanding where she is, also involving her in the decision making. When we ask what would you like to us to do, that is also information gathering. Okay, so obviously learn that skill till then. One more question before we go to the next one, and then we can
Dr. Safia, is this a good idea to finish the main chunk, like you said, it's a counseling or it's a delivery plan or it's something else. So to finish that and then to ask about these small things like information gathering if necessary for few things. So in that way, I am thinking that we will be able to finish the main portion, which is important, having got a numbers first, and then, for example, information gathering, even it is not complete, but we will get some marks because that is the main time, this information gathering takes the major portion of that time slot.
So basically, as we did talk, I always talk about is like what I think that's just my natural style as well. I do go into the detail if there is any reports, any investigation to be discussed, the scan report and everything. Now, in this particular scenario, obviously, I do understand, other than knowing that what has been done till so far, what she understands about her condition, there's nothing else from the history I will gather which is going to affect the way I'm going to explain her these results and options. Okay, so and she's anxious, so I always start, I will start from explaining the result report or scan or
Yeah,
whatever is given over there,
right.
and then it's
Yeah.
natural to give her some initial information about it. Yeah, so we gave that in a generalized way, that in these circumstances, these are the options. Either we deliver them, and if we don't deliver, what will happen, or if we don't deliver and then go that way. And then before I could ask her what will be option, what would you like us to do, then I gather the information. Because if there is some any other additional factor or something like that, then I might counsel her about the management options in a different way. And if not, at that stage, I will take that focused history, which is relevant, and then I will explain her further management plan. So this is all in my style, the information gathering, unless it's the first, kind of just the GP referral sent to me by saying this patient has amenorrhagia, I have tried this, and now this I'm sending to you, then obviously I will start from history taking. But these type of where is already ongoing care going on, and between now we have something different, and we need to explain and counsel the women. It's just natural to explain the result, whatever, and then take the information and then explain the management plan or the options.
Yeah. So I was like, I just want to, I need your opinion that if we are taking the information gathering in the last portion, so it will not put a bad impression. So like, it's not a following the template of the proper histories. Like,
Okay, so if it's not natural, so say, for example, you have done everything, you discuss the report, you discuss the management option as well, everything, and at the end, the time is left, and then you start gathering the information. That's obviously not going to have a good impression, because there rather will say, if you discuss the management plan, basically without knowing what will be the best management plan for this woman, keeping her medical and everything else in mind. So
yes, yes.
keep it simple, explain the result. And if you feel, so most of you probably, again, because you might have done some other courses, the way you have been trained till so far, mostly people feel that we need to do history in the beginning. Because
Yeah.
this is how we are tuned. Otherwise, I will forget or I may not feel confident. I feel still from now till the exam is still enough time for you to actually alter your the habit and become more natural. If you feel no, still I will be messed up otherwise, then at least learn that how much I need to ask in the history. Don't then just blindly go about everything.
Yeah.
Smear, smoking, who you living with, what you do, what work you do, and what you know. I mean, it doesn't matter here what professional this woman is, what job she does, whether she, smoke, whether she drink, whether this, for this woman, I won't be going in those questions. Yeah.
Thank you very much.
Yeah, so try to work on one of these two. I would obviously, still we have the time, still you guys have the time, okay? There are like 2.5 months. You still can change your style to become it a more where you can play safe and more natural and more confident. But obviously I can't just give as a rule. Okay, who is next?
Myself.
Okay then, this is for you.
Okay, that's your first 2 minutes, Pramila.
Yes. Hello. Good morning. I am Dr. Premila. May I confirm your name and age, please?
Yes, doctor. My name is Rachel Smith, and I'm 41 years old.
How should I address you?
You can call me Rachel.
Okay, Rachel. I see that you are 41 years and you are now currently 13 weeks pregnant, and this is your first pregnancy. And you had done some blood tests and scanning a few days back to find out your risk of having genetic problems, and you have come here for the report. Is that so?
Yes, that's right, doctor. I'm actually really anxious and nervous at the moment. I had the test done for Down screening, like they did some scan and some blood tests as well. And they have told me that there is very high chance that I will have a baby affected with Downs. So, it's absolutely devastating news for me. So, I really just want you to tell me what can be done and what should I expect?
Okay, Rachel. So since you already know about your report, so according to your age itself, you to begin with, you had a high chance of having a Down's baby. But at the same time, all this blood after doing these investigations and scanning, actually the risk has a little more increased. For according to your age, your risk might be around 1 in 100. But after doing this test, it is showing that there is a risk of 1 in 74. So don't get too much worried. This is not a diagnostic test. This is just a screening test. That means we are doing it all to find out who might be at high risk of having a Down syndrome. And having a high screening result doesn't mean that your baby is having Down syndrome. When we say there is 1 in 74 risk, that means out of 74 people who comes with this report, one might be having Down syndrome. The other 73 may be still normal. So don't get too much worried. But at the same time, as I explained, the risk is quite high. We usually keep the cutoff risk as 1 in 150. So your risk is, from your age itself, your risk is already on the higher side. To add to that, this test has also come as a high risk. So we will have to do further little more tests to find out whether actually the baby has got Down syndrome. So by doing these tests, we can't determine that. We will have to get, ideally, we will have to go in and take some tissue from the afterbirth of the baby, which we call as chorion villus sampling at this point of time, with which we can do the actual genetic study of the baby. And in that genetic study, we will be accurately able to tell you whether the baby is having Down syndrome or not.
Right.
Is that clear?
Yeah. So what is that test, and are there any risk or complications of that test, doctor?
Yes. So since we are doing an invasive testing, we have to go into your tummy and take this test. There are little bit risks associated, even though with the newer technologies, the risks are quite low. But around there is 1% chance that while we do this procedure, it might affect your pregnancy. It might end up in produce a miscarriage, or it can produce problems to the baby. But when we compare the risk with the of this blood investigation and the scan report showing the risk, we can actually balance the benefit. It's more towards the beneficial side that we have to do this. Or else, if you are too much worried about doing at this point of time, we can postpone it little more later to around after 15 weeks, where instead of going into the afterbirth, we can actually go into the fluid around the baby, that is the amniotic fluid, and from that also we can get the same report. And with that, actually the risk to the baby will be little less than what we are doing now, because the pregnancy would have obviously grown more. So the chances of complications will be little less when compared to this procedure, which we call as chorion villus sampling. So amniotic fluid testing might be a little less complicated. Yeah. And before we proceed about deciding about what to do further, let me ask you a few questions because you are 41 years of age. So apart from this risk, there are other risks also associated with you. So when as age increases, the chances of having generalized diseases like hypertension, diabetes, all increases. Do you have any such diseases so far?
No, I don't. No, there isn't any.
Okay. Okay. And how long have you been trying to become pregnant?
Well, I got pregnant within about 6 months when I started trying.
Okay. Oh, okay. And how much is your height weight ratio, BMI?
That's about 24.
24. So that's good to know that you don't have a high BMI. But
Yeah.
do you smoke, use alcohol, or recreational drugs or anything?
No, doctor, I stopped smoking and drinking everything before I started my pregnancy.
So for you or for anyone in your family, there is a risk of clot formation in your legs or lungs?
No, doctor.
No. Okay, that's also good. And do you have any, are you on any other medications other than the vitamin tablets which we are being given?
I take some medicine for asthma.
Okay.
And I'm taking, yeah, that's all I'm taking.
Okay. And is your asthma well controlled?
Yes, it's quite well controlled. I just take blue inhaler when I need.
Okay. I hope you don't have to take it more than 3 times in a week.
No, just not even sometime in a couple of weeks, once maybe in a couple of weeks' time.
Okay, okay. So that's also good. And do you have any allergy to any drugs?
No, I'm not aware of any allergies, doctor.
Okay. Any surgeries done previously?
I did have one laparoscopy done, and that was done to remove my gallbladder. I did have some stones.
Okay. And did you have any problems during that time of anesthesia or something?
No.
Okay. Okay. So other than your age, I don't think there are much other risk factors for you. But you will have to be on close follow-up to, because you are at risk of developing hypertension and diabetes. So we'll have to keep a close follow-up on you. And as I told you, these are the two options which we will have to go about to find out whether actually the baby is having Down syndrome. And there is actually one more method which we can use, but that is called as NIPT. That is, here we don't have to go into the womb. We can take your blood, and in your blood there will be baby cells will be there. Through that we might be able to reach some conclusion, but it is not as accurate as doing a invasive testing by taking the tissue from inside. So even after doing that, if it turns out to be negative, still there is a 1% chance that the baby might be having Down syndrome. So if you want to be 100% sure, it will be better if you go directly with some form of invasive testing. And I will be discussing this with my consultant, and we will also discuss with the fetal specialist who will be doing these procedures. And I will be giving you some written information, and you can discuss it with your partner. And once you decide which one you want to go, have you reached in your mind, what do you think now? Do you want to go ahead with the testing now?
No, I will need to discuss with my partner because it's really difficult. That obviously I would like to know, but if I go and have a miscarriage, that's something. So okay, so could you tell me about if the baby is affected? So if I go for the test and it says the baby is affected by the Downs or something, then how is that going to affect the baby, and what I will need to do, because I wouldn't like to go for termination or anything. So I would like to know that in case that happens, how are you going to look after my pregnancy, or how the baby will be affected?
Yeah, I fully understand your concern. Taking care of during your pregnancy, as such, having a Downs baby doesn't change much in your pregnancy, other than the problems that can happen because of your age. But apart from that, after delivery, Downs babies usually are found to have a low IQ. Their mental capacity, their learning ability might be less than the normal babies. And Downs babies, actually there can be different varieties can happen. Some babies might be just affected with this learning disability. Some babies might have more form involvement, like heart diseases can be there, or sometimes there can be problems with the eyes. So many other things can also, other systems also can get affected. On that we can actually find out, we will be able to do a echo. If you want, we can do a fetal echo at around 20 weeks and can see whether there is any significant cardiac problem for the baby. But apart from that, the other things, it might be very difficult to find out during pregnancy. So as and when the baby delivers, then only we will be able to, as the baby grows up, only we will be able to find out actually how severely the this is affected. But nowadays we have got good support groups available. There are special schools for such children, and we are seeing that many of such babies actually uh, grow in their life very well. They do well when compared to the previous years Downs babies, because of the newer facilities available. But it will be a really tough situation for you to deal with, and to, you will have to be with the baby and you will have to give sufficient care to the baby. So it will be demanding, but as and if that need arises, we will be counseling you for that, and we will be giving you more information. Is that okay?
Okay. Yes, doctor. So you said like these babies can have some effects on their heart and their eyes. So is there any other organ of the body which can get affected as well? Like
there can be renal problems can also are sometimes seen, but mainly these are the main two organs which we usually, and sometimes the stomach, in the stomach there can be sometimes block. So there could be problems with the which we call as duodenal atresia. So there might be some problem with the food going in properly through the stomach. So for that we might have to consider sometimes surgeries later on.
all right, okay.
And I hope your partner is supportive, because it will take a lot of effort from both of you to take care of such a baby if suppose such a situation happens. I'm still not saying that baby will be affected, because as I said, there is only a small chance that the baby will be affected. 73 times the baby is going to be okay.
Okay, right.
Okay. So just go back and discuss it with your partner and with other family members also if you want. I'll give you some contact numbers and support group details also. You can talk with them at any time if you want further consultation, or if you want to talk with us, you can always get back to us.
Yeah, that's okay, doctor.
Thank you.
Thank you.
Thank you. Thank you.
Okay, thank you. Thank you, Pramila. Done nicely. The only thing I will be worried about is to refer to her age so repeatedly. I do understand what you mean by age, but the way we need to say is a bit different, yeah? So, right, so how we can say, from factual and the facts and theoretical point of view, it was good. It was nice. There would be only a couple of things I would like to ask. Whenever we have some screening test and that come as a high risk, obviously, yes, this is how we need to discuss the options with the women. But we then must need to ask them before we actually go for their diagnostic and invasive testing. We need to basically first assess them. What would they like to do with the result? So if there is a woman who says, just like as I said, I wouldn't like to go for termination anyway, even if this baby is affected. So if she doesn't want to go for termination, I need to then explore her why would she like to take a risk of 1% then of miscarriage for doing CVS or MNEO? I mean, 2 to 3% for CVS and MNEO. Yeah. And the answer may be, I mean, she still says no, but then at least I will know by certain, what I'm going to have, and I will be more prepared. So then it's fine. And sometimes some women will say, well, yeah, no, I'm not gonna, and so, I will have the information, but then we will see when the baby is born. So it's very important. Whenever we go for any diagnostic test, we ask with them first that, what you would like to do with that test and how you're going to deal with that test result. Okay, so and then obviously to help them to decide that, then we also then need to give that information. So that's why I asked you particularly what the Downs syndrome babies, what problems they will have. Yeah. So if we again, here is something where we are going to offer them some procedure which carries some risk of miscarriage with it. So we need to give her full information, basically, what that baby is going to be like. So, after knowing that it is compatible with life, it can done, like it's not that bad. And, there will be 20-week scan when I will be able to
That will also help, to decide if there is any cardiac defect in the baby or anything like that. And then maybe we can do down screening at a later stage. Or if not, baby is fine, then the chances of effect will be low. I will be fine to know that. So it's important to tell what down actually will involve. So for this woman, yes, 41 years old, you will start by saying, that I can see you're here, you have some tests done and you're here to discuss the results. And again, openly ask her question to before we start. Just start with her to by saying, okay, so would you like to tell me what are your concerns or what you know about the test you have done already? Okay, so let her tell. So then she tells you, okay, I have that screening test done. They said, and they told me that I'm at a high risk of having baby with Down's syndrome. So instead of saying the word that no, you may have Down's baby, or you have, the babies, I will say there is high risk that your baby may be affected by Down syndrome. Yeah, the baby may be affected by Down syndrome. So after her information, which she had, I didn't do these scans and stuff, and I have my result has come like this. Then you can say, yes, I can see I have the report with me. And then, this report shows that the risk of your baby being affected by this condition we call Down syndrome is 1 in 74. Means if there are 7 pregnant women exactly under your circumstances, matching everything, age and everything else, then out of 74, 1 baby, may be affected by the Down syndrome. So I will, like you not to get too alarmed. It only gives us the idea about the risk. This is not the, the diagnostic test, right? It doesn't say that this baby is affected by Down syndrome. So first reassure her. And then you can say, so from here, then what we can do now, because when this risk assessment is done, 1 in 74, that means her age, all other factors have been counted already. Okay, her nuclear translucency, her blood test, her age, that all has been already calculated. So I won't particularly mention about her age by saying that you are high because of your age, because that counseling has taken place already. Okay, and even if you want to say, you can just simply say yes, because that the age more than 35 years actually increases their risk slightly higher than average women. And then these calculations are part of your result, but basically result is there now. Yeah, risk is there now, so you don't need to worry about the age particularly here. So then we can say, okay, so after giving that information and reassurance, then you will say, so what here you can do, obviously, again, that just is giving you an idea that 1 in 74, there are chances that the baby may be affected by Down syndrome. So no, obviously, there are few options here to go forward from here. The one is some people do not want to do anything about it. They just, want to just let the pregnancy progress and then just have the baby checked when the baby is born to see if the baby is affected with Down syndrome or not. Or some people, however, some people would like to get more information, and that can be in 2 different forms. We do have one further screening test. We call it, self-free testing of the baby, simple another blood test, basically, in which we would just use, the genetic material of the baby and yours to then determine the risk. That test too will not be a diagnostic test, but that will narrow this risk more. That test will be able to tell us the risk more closely. There's more sensitive test we can say. So that can narrow the risk more. Maybe when we do that test, so use the word maybe when we do that test might say this risk is, maybe still 1 in 70 or 1 in 74, or they might say the risk is 1 in 5. So they will give more precise idea. They will narrow the gap between more sensitive result, we can say. And then depending upon, then you can, decide whether you would like to go for more invasive testing to actually confirm the diagnosis or, exclude it. So those tests are called, we called them, in one test we take some sample tissue from the afterbirth of the placenta of the baby, having a direct look by the ultrasound scan at the same time. That test can be done up to 14 weeks, which means we can actually arrange that test to be done within the next 1 week time. However, that test, and we call chorioamniocentesis, however, the tests do have a risk of 2 to 3%, like 2 to 3 out of 100 procedures that has a risk of miscarriage. So that is something I would really like you to keep in mind, because there can be some regret associated. Say, for example, when the test is done, on the report, and as a result of that risk, the women have a miscarriage, but when the result come back, that's normal. Then it can be sometimes, some women find it quite difficult to deal with. However, obviously the risk is very small. There's only 2 to 3 cases out of 100 procedures being done. So this is very important again, because in these type of invasive testing, when we inform them, we help them, we need to help them to understand exactly what possible outcomes can be. Yeah. And then you can say, what we can do then, we can delay this testing a little bit more further, up to about 16 weeks, 15 to 16 weeks time, when the water on the baby will become more increased. So then in that case, then we can just collect the water around the baby. Again, having a look directly by the ultrasound scan, and then do the same test with that fluid sample. The advantage of that test is that obviously reduces the risk of miscarriage. There is a risk is less, like only 1 out of 100 procedures, one woman may miscarry. And the next day you can check with her, like, so how you feel about this, what you feel you would like to do. So then obviously she will come up what she wants to do. She might say, no, well, okay, tell me what down actually is, or what is not, what is. So if she's not clear about anything at this stage, you say, well, I don't really know at this stage, I need to really discuss with my partner. Then you say, yeah, that's absolutely okay. You do have a time at the start, like you can do, if you wanted to do for that test of the placental tissue, that still can be done within next 1 week time, and the other blood tests we can wait even up to 16 weeks. So I give you some information about what Downs is, and then again assess our knowledge already. Do you know? Have some idea about what Downs syndrome is, and how it affects the babies or the children? So if she has any idea already, that's fine. Include that and just tell further information. If she doesn't, she says, well, not much other than that they have learning disabilities. Then you can say, okay, so this is the a condition which is because of some imbalance in the genetic information at the time of development, when the pregnancy starts. The way it affects the babies, there can be effects on the development of babies' certain organs and the appearance of the face appearance of the baby. It can affect, you can say, the development of the baby's heart. It can cause some defects in the baby's heart. And it can cause, narrowing or complete occlusion of one of the bowels of the baby. It can, affect their learning ability as well. However, so we will be able to do a detailed scan, which you will have done by the specialist doctors. We call them fetal-maternal medicine consultants at 20 weeks. So that scan, which also will give you quite a lot of information as well, on the structural development, on the development of the organs of the baby, if it's affected or not. However, the babies with the Down syndrome, not all of the babies have these defects. Okay, and then it was very good to explain that Down syndrome, the effects can range from very mild effects to severe effects, both on the physical as well as the mental development of the baby. Physical means on the heart defect, and like how major they are, and also the learning ability of the baby. However, there is quite recognized condition, and there is a lot of support available about that. And there are like proper societies and organizations who provide support to the parents who have the babies and the children with the Downs, affected by Downs, both for their babies, those children's physical as well as their mental development. Okay, so there will be quite a lot of that sport being done. These babies, children can go to school, they can be quite easily trained, and many of these children, are living quite normal lives with a very minimal assistance. However, obviously it varies depending on how much the baby is affected by this condition. The life expectancy have also increased with the people with the Downs. And then, if particularly that person asks you, then you can tell about like up to 40 to 60 or whatever. Otherwise, don't tell about the number of years. But this is how you will tell about, yeah. And then you can say, so that's the information. I'll give you some written information as well. Now, obviously, I can understand it can be quite anxious situation for you, and particularly when you have to make the decision about what would you like to do. So if you like, no, obviously this is not some very traumatic and shocking condition that I automatically should go and say, but I can see this is absolutely shocking thing, and how you feel about me arranging you counselor. Rather, because it's a kind of moderate, mild type of situation, mild, moderate. All I will say, I can see it can be, I understand it can be quite difficult and stressful situation for you to actually consider all these things and then take some decision to whether to go for testing or what. If you feel you find it quite stressful to cope with, or your partner, please let us know. We can arrange some counseling for you. And particularly, and sometimes, not sometimes, we do offer these women as well. If they like to, if they would like to, we can actually give the contact details of, Down Syndrome Society and also the group, so they can speak to them as well to get more information about, and also to know about the day-to-day life of the individuals affected by Down syndrome. Okay, and then you will say, so when you feel ready, just let us know. We can arrange that test for you. Any quick questions?
Dr. Safia, is NIPT paid by the NHS? Is it a free testing?
No, it's not. It's not.
Doctor, that the new guideline that came for the NHS for the Down syndrome screening and testing, few of the trusts have adopted about this, huh? That
It's
they are
very
offering.
individual. Yeah, it's very individualized at the moment, and even the trusts which are providing them, they individualize it as well. So it's not available as a screening to all the patients. So maybe some very different circumstances where somebody has come as a very high risk, say, so just like this woman, maybe she's 41, 42, where we know her further fertility chances are low as well, and all that stuff, and it's really important, and it can affect her decision taking. Then on individualized basis, this test is being offered. But I would not go into the details unless that woman says, yes, I would like to go ahead. That is more administrative issue for us to see whether we can do an NHS funding as NHS, or she need to pay. So I wouldn't go into that detail, because obviously that's a bit individualized case. But yes, it is available in NHS, kind of more.
But we will offer
Specialized cases. I will offer, yes.
Okay. Thank you.
Okay.
Dr. Safia,
Yeah.
why I need to offer her NIPT in this case, as long as it is still screening test? The diagnostic will be the needle test.
Yeah.
So better to go like for needle test from the beginning.
Yeah. The reason to offer is, as I said, like some people would like to know more narrow range. So say, for example, if I have a dilemma, it comes as a 1 into 74. And you have told me as well, like there can be a risk of miscarriage, 2 to 3% or even 1% risk of miscarriage. Now, I go for a test. Yeah, I go for a test, and then unfortunately, I'm that 1%, so I have a miscarriage as well. And then the test report come back, and that come back as a normal. Now you can imagine how traumatic it can be for that woman. So doing this NIPT test, that actually narrows the range further. Okay, we do know the sensitivity is very high. So if that come as a higher risk, come back as a high risk, we can offer that woman to say, well, you can. But if that comes as a low risk, then so there is something like we call as a sensitivity and specificity. So if NIPT come as a low risk,
the specificity of this test is very high. Okay, so negative means a low risk means we can quite easily reassure that woman that actually the real risk of your baby being affected with Down syndrome is low. It's not what has come from those tests, right? So then she may choose by saying, okay, no. But there can be some people, on the other hand, which will say, even if there is a small risk, I would like to know, yes, I'm ready to take the risk of miscarriage, but I would like to know whether, and that's only a blood test. So it doesn't cause any harm to the baby, doesn't cause any harm to the mother. That helps for decision making. That's the reason.
Hello, Dr. Safia. Dr. Safia, my one query is my mind. Okay, in this woman, the screening came 1 in 74. Okay, so with NIPT, it will means more narrow, or it can be even like suppose it can become as a 1:80, 1:90.
Yes,
it can,
yes, it can come. Yes, it can come. Yeah, that's
that is
more
my query.
specific because that's a DNA test. Yeah, so that one can take her risk. There is equal possibility that might come back as a 1 in 100 or 1 in 50. Yeah, so that's more specific, and that's why we do it. That helps them to take the decision. So yes, you will, because this test is there now, it's available, you must offer that before you go for invasive. But if somebody says, no, I would rather, instead of having that and going through the stress of waiting their result and then go for that, I would rather like to do the diagnostics test, then that's their option. That's their then what they want to go. Yeah, our duty is to, again, inform them and offer them what is available and help them in decision making. Right. Okay, who is next? Quickly, girls.
Rabab.
Somebody asked, do we need to explain in report detail about NIPT when results will become? No, of course not. You won't have the time to do that anyway. Rabab, this is for you.
Yes, yes, Dr. Safia.
Okay, so your first 2 minutes.
Okay. Okay, doctor.
Okay, you ready?
Yeah.
Yes, you can start then.
Hello, I'm Dr. Rababan of the doctor on duty today. May I confirm your name and age, please?
Yes, doctor, my name is Dawn Bird, and I'm 41 years old.
How you want me to call you?
You can call me Dawn.
Okay. I understood that you came today. This is your first pregnancy at 35 weeks gestation, and you are planning for home delivery, isn't it?
That's right, doctor. I want to deliver home, but the midwife told me that I can't have the home delivery. So she made this appointment for me to come and discuss. So I'm really looking forward to, I had this plan done to get delivered at home.
Yeah, sure, your concern will be addressed, but I would like to ask you a few questions. At any time you have anything not clear, don't hesitate to ask me. Is it okay?
That's fine, doctor. Thank you.
Okay. So, why you want home delivery?
Well, my sister had delivery in the hospital just about a few weeks ago, and I just did not like the environment. There was so much chaos, and they were like, and then she ended up, there was like doctors coming in and out, and then they delivered her baby by cesarean section. They put her needles, cannulas, and I don't know, all that stuff. And I don't want that, any of that. I just want to have a nice, straightforward, natural birth at home in my own environment.
Yeah, sure, your concern will be addressed, and sorry for what your sister passed through. So can you tell me more about your pregnancy?
My pregnancy is fine. It's been straightforward. I'm doing okay. There's no problems. Like, I haven't been told anything at all about the baby or about my health.
Good. And when was your? Can you tell me more about your last period?
My last period, I don't remember my last period, doctor. I'm 35 weeks pregnant.
Okay. And otherwise, you don't have any health issues. You are visiting your doctor?
No.
Okay. Do you have any surgeries before?
I did. I had my appendix taken out, and then I had one cyst taken out from one of my ovaries as well in the past.
Yeah. Okay. And do you have any allergy to any medicine?
I am allergic to penicillin.
Okay, sure. I will record this in your notes, and we'll make sure that you are taking the correct antibiotic. Otherwise, do you smoke?
I smoke. I have cut it down though. Currently, I'm smoking only like about 2-3 cigarettes a day. I'm trying to cut it down.
Okay, good. If you want also any help regarding smoking cessation, I can refer you to the NHS smoking cessation service.
Yes, my GP is already helping me to quit. Thank you.
Okay, thank you. And do you have? Do you drink?
No,
Alcohol?
I'm not drinking in pregnancy. No.
Okay. Do you use any recreational drugs?
Oh no, doctor, no.
Okay. What do you do for living?
I am a school teacher.
And do you have support at home?
Yeah, I live with my partner. He is supportive.
Okay. Do you have any family history of concern? You want to share it with me?
No, I don't know. I don't know.
Okay. How is the baby kicking?
Yeah, baby is moving fine. Baby is quite active, yeah.
Okay. Thank you for sharing the information with me. Coming to your examination after your permission and in the minute of February, I would like to check your heart rate, blood pressure, and temperature. And I already have your height to weight ratio, which is 36. And already I need to examine your tummy also after your permission. Is this okay?
Yeah, doctor.
Okay. I would like to tell you, after confirming your NHS number and your name, that your ultrasound that was done for you, it's showing the baby is growing well, and his head is down. I want to draw to you. This is your womb. This is your baby head. It is down. This is normal, and the afterbirth is fine, and everything is fine. But you have something called fibroid, which is around 2 to 3 centimeter in size. Are you aware about it?
Yeah, she told me I have a very small fibroid.
Yeah. Okay. So I want I agree with you that home delivery is a good option. There is no intervention. You have support by your family, your partner, and also you have early access to deliver to breastfeeding, early skin contact, and you are delivering at your home. So I know that it is a comfortable option. I really agree with you. Yeah.
Okay.
Yeah, but you know, in some conditions, it is having some issues, and sometimes it is not safe because there is a delay for access sometimes to the operation theater. There is sometimes there is delay of progress of labor. Sometimes there is a need for the help by the baby doctor, and sometimes we need the anesthetist to be around to do an operation or to give you more options regarding analgesia.
No, that's what I
So,
don't want, doctor. I don't want these interventions and stuff done. I
yeah.
will do it naturally.
Yeah, I am supporting your point of view, but let me explain you regarding your current pregnancy. You are at 41 weeks gestation, and this is your first pregnancy, and your height to weight ratio on the higher side. Are you were you taking aspirin during pregnancy?
Yes, they gave me aspirin. I'm taking it regularly.
Okay, so I'm afraid on such a condition you have some risks in order to deliver it at home. I'm afraid that it will not be a safer option for you. So
And why is that, doctor?
yeah, and we will need at 36 weeks. We'll tell you the plan of the delivery because we might need to deliver you by you either you go spontaneous labor or we might induce you because we don't want to have any problem for the baby sometimes dying in your stopping the baby heart in the womb because at the 41 year age and with the first pregnancy, we need to deliver you before 40 weeks. So this might be by either spontaneous or you go for induction of labor. Am I clear to you?
Yeah. Okay. So if
Yeah.
I don't start labor pains by 40 weeks, you're gonna induce me?
Yeah, because this is safer for your baby.
Okay.
Yeah, the other issue that your height to weight ratio on the higher side, and this might brought you to problems with the baby, like difficult delivery, sometimes stuck of the baby shoulder, and for you sometimes we have some injury from down below, injury to your frontal or back passage, and sometimes need for delivery by cup or spoon or even by cesarean section, and it's a problem. So we need also to refer you to the anesthesia doctor and consultant obstetrician and the baby doctor in order to be safer for you in your condition. Am I clear to you?
Yeah. Yeah. So I mean, that's what I'll want to avoid. You say, and so that's what happens in the hospitals. If I'm in the hospital, you guys will be poking me with all this stuff, and just take me to theater and all that stuff, and I don't really want that to be done.
Yeah, your safety is the
Yeah, I mean, you know, if so, you said if I don't deliver by 40 weeks, then you will need to induce me. Okay, that's something then, you know, I can consider. Well, if I don't go into natural labor by 40 weeks, then if you really need to be induced, then I guess I will need to come to the hospital. But if I go into labor before that, then am I okay then to deliver at home?
you still have some other risks and like your height to weight ratio on the higher side, and you have the fibroid also in your womb. You might experience some excessive bleeding after delivery, and we might be ready with some special measures like special medicine we are giving you after birth, or some maneuvers in order to help you in that way.
I mean, I live very near to close to the hospital anyway, just 5 minutes drive from the hospital. So if obviously, I understand obviously, yes, if I bleed or then you will need to give me some help, and I can just come to the hospital then if I started
So
bleeding.
I really recommend you to share the opinion with your partner and your family, and you can also go for an option of alongside midwifery unit. This can be an option. I'm going to give you an appointment with my consultant, and I'm going to give you a patient information leaflet. Also, you can go through and think about it again, and we can discuss this issue in the next visit.
So why I need to see the consultant?
Because your pregnancy is considered as a high risk pregnancy because of the things that I already mentioned to you.
Okay. Right.
Do you have any concerns? Any more concerns?
No, but I'm fed up with this repeated appointments. I mean, I discussed this all with the midwife. She made my appointment to see you. Then now you're making my appointment to see your consultant. I mean, I'm still not going to change my mind. I mean, I do understand what all you said. So yes, if I don't go in labor by 40 weeks, okay, I will come to the hospital for induction. And if when I'm delivering at home, if I start bleeding, I will come to the hospital. So what's the big deal?
Because this is affecting, I'm afraid that this is affecting your safety and your baby's safety. That might, it is life-threatening for you. It might affect the baby. It might end in something called cerebral palsy, and it affects the baby dramatically. So I'm sorry to tell you that, but
Cerebral palsy,
your
doctor. Why my
safety is
baby will have cerebral palsy?
because of some delay in case cesarean section is needed, and it will take time to go from your home to the hospital and to the theater, and arranging the staff and arranging all the things for cesarean delivery.
Why should I take the delay, doctor? I'm only 5 minutes away. I'm literally down the road.
Okay, at the end, it is your option, but my duty is to clarify the things for you, and still we respect and support your wishes.
Yeah, I appreciate that, doctor. Thank you.
Thank you.
Bless you, Rabab. Okay, that's fine. Yes, you did. Raise this concern. Yes, this woman shouldn't deliver at home. Maybe we need to. The two things I picked up is only what was not safe for me was like if I start bleeding, I'm in a cesarean section, or if I didn't go into labor, I need induction. And that's why I'm just, focusing on those points and telling you, yeah, that's fine. If I don't, then I will come. And if I bleed, then I will come to the hospital. That's it. We need to tell why, when we're saying it's not safe for you, then we need to elaborate a little bit more why it's not safe. Why, although you live only 5 minutes down the road, still it's not convenient, and it may not be because of your BMI and all that. Your transfer to the hospital will be very challenging, and that will delay. That will be the reason to delay. So to start with, so in history taking, do you have any family history of any concern? When I'm already overwhelmed with my pregnancy and everything, coming fed up with the midwife already not letting me deliver at home, and has made me to wait here for 1 hour in the waiting area before I can see you. I'm already bit like, I'm not going to change my mind anyway, she still just made me to sit here. And then if you will ask me, is there any family history of concern? To be honest, that's least on my mind. And even if there is a clear family history of cancers and VTE, my mom might have died just a week ago with VTE. Probably I'm not going to think state at least that that is something to be concerned regarding my pregnancy. So please be clear about what we particularly want to know, yeah? So in this woman, particularly when her BMI is high, we need to very clearly ask her, is there any history of blood clots in legs and lungs you had in the past, or is there any family history of blood clots, yeah? So ask very clear question. I was very happy when you started, right, in the beginning, and you said, I agree with you. So you raised my hopes quite high. You actually certified and verified that I was right to think about that's a good idea. So I wouldn't say to that woman, I agree with you, that the home delivery is good. I will tell you how we will say that though. And then we will make your appointment at 38 weeks, did you say, or 36 weeks to discuss your mode of delivery and you know, of induction or whatever. No, she's 35 already with so many of her respecters. We don't want to further delay, leave it 2 more weeks to before we start, you know, make any plan. We need to make plan now, whatever, either way. Whether she wants to deliver, which way she wants to deliver, and then put all those arrangements in place. So I wouldn't leave her for 38 weeks to discuss everything all again. Okay. So yeah, so when you read this scenario before you start, obviously there are risk factors. Yes, age, her BMI, she has a small fibroid there as well. So these are the main concerns, and she wants to have a lovely home delivery. So first of all, you need to start. Start was absolutely fine to start. I understand you're here. You want to discuss your plan of delivery. So would you like to share with me your ideas and your wishes, what you want us to do? So again, like some kind these type of conversation where you feel there might be a little bit of conflict, but we tell her, just start with the opening to give her open, thing to first let her tell her ideation, what she is thinking, so that we can assess how we're going to approach and speak to this woman. So she then tells all that tale story, which can be sister's bad experience, maybe friend bad experience, or her own bad experience, whatever that is, just listen, acknowledge. I can say, this must have been very difficult, or I'm sorry that your sister or you or whoever had to go through, through that stressful situation. And then you will say, so, and then she says, okay, I want to have the delivery. Then I will say, uh, I guess you wanted to say that, the home delivery can be a good option, yeah, but not for everyone. So for her, I will say, I can see that you want to deliver at home, obviously for all those good reasons. However, the home delivery cannot be a safe option for everyone. So before we plan for home delivery for any woman, we do some assessment to make sure that it will be safe and convenient for the woman to deliver at home. In your particular circumstances, I'm afraid we will not recommend you to deliver at home. For a few reasons. So number one, you can start, I will start basically from a bit less personal aspect. So I will start from fibroid, although that probably is the least reason, but I will start from here. So I'm not straight away going to start about her age and BMI, because that's a personal, can be a bit sensitive thing to start with. So I will start with the best I will say. So I can see you have one small fibroid in your womb. And the position of that fibroid is right at the top part of the womb, where your afterbirth is also attached. So these fibroids actually are just small overgrowth of the muscle, and they actually take a lot of blood supply. Okay, so what happens with these fibroids, and if your placenta is directly, because your placenta is attached there as well, so it may be, there can be a possibility your placenta, part of placenta is actually attached above the or on the fibroid. So as a result, the blood flow to that part of the placenta can be reduced, particularly during the labor, when you will be having the contractions. During the contractions, the blood flow to the baby is temporarily reduced because of the uterus, the womb going contracted. That can result then at that stage with further reduction of blood flow to the afterbirth and to the baby, or even the part of this afterbirth that the placenta can separate from there, from the top of fibroid. Okay, and if that happens, that can lead to quite heavy and life-threatening baby, which can be life-threatening for yourself and for the baby. All right, so that is one of the reasons. And if you start bleeding quite heavily, then, there will be something we will need to immediately then, shift you to the theater to deliver the baby and separate the placenta from there. So if you are at home, then it can delay your transfer to the hospital. And no, I'm going to, from here, I'm going to creep on her weight. And I also noticed that your weight to height ratio is 36, which is towards higher side. So that itself has some complications, that will make your transfer to the hospital, particularly in that emergency situation when you're bleeding quite heavily and there might be some threat to life of your baby as well. This transfer can be quite challenging and it can delay the transfer, and obviously it can seriously compromise your baby's life. So that's what I have done. Then I will say, and then, another reason for you not to recommend to deliver at home is that your age is more than 40. So for the women whose age is more than 40, we strongly recommend them to deliver in the hospital, because the evidence has shown that, in these women, their babies can die during the labor for unknown reasons. And for that reason, we like to continuously monitor the baby's heart with the heart tracing to keep an eye. And at any stage, if we have any concerns, so that we can then deliver that baby immediately with the cesarean section. So that monitoring will not be possible at home. The continuous monitoring will not be possible at home. The midwife will then end up try to listen to the baby's heart with their stethoscope, which, because of your weight, can be challenging, because it can be quite difficult actually to detect the heartbeat, and particularly during the contractions. So the midwife won't be actually clearly able to keep an idea about the baby's well-being during the process of labor at all, and obviously that can be quite dangerous. Okay, so these are few things I will start with simple. And then I will say to her, and then obviously the other thing that was fine actually to tell her, because of her age, BMI, whatever, we would not like you to go beyond 40 weeks. So if you didn't deliver by 40 weeks, we like to do is, we might actually we may plan to actually induce a delivery you around about 39 weeks. But at least minimum is like, we wouldn't like you to go beyond 40, and then we may need to induce you. And obviously that's not possible at home, because that will also require continuous monitoring. So after these initial few ones, I will ask her how you feel about this after all this information. And then if she still says, well, I'm just down the road and, I can come down, and you can say, even, being in the hospital, and it's more easy, immediately transfer to the hospital, to the theater, but from home, it will cause delay. Then you go for other reasons of her age and what risk factors can be. Then you can say during the labor, when your weight is high, there is a risk that the baby's shoulder may get stuck at the time of delivery, and that will then, we call it shoulder dystocia, and that will require then specialized maneuvers in a particular position. We may need to then push your legs in a particular position, which obviously is not possible at home, because we do need a specialized type of beds for that. And then in those circumstances, that even without that complication, when the baby is born, sometime the baby may need some assistance and help with breathing and oxygen, which probably will be again challenging at home. Okay, so for all these reasons, there can be a risk of bleeding as well after that, quite high bleeding, and for that reason, and because of your BMI, you will have, actually, we would like to pass you cannula, to keep the cannula in your hand even at the beginning of the labor, so that in case if you start bleeding or anything like that, then we can immediately start you on some fluids or the blood if required. Because during labor, the hands, and the arms, they can get even more swollen, and then it can be quite difficult and challenging to find the the veins to put these cannulas. And for that reason, we would like you to be seen by and assessed by our anesthetist as well, which will arrange your appointment to be seen next week. so that if for any reason you need any cesarean section or you need, need any fluid in case of bleeding or anything, then the anesthetist has a plan in place. Okay, so the history taking was fine. The information which you took, that was fine. So then you will say, I will recommend you. Then you ask her how you feel about this after all this information. Hopefully, by that time, the way if you have given her clear information, she will say, yeah, okay, I can do that. Or she might say, okay, right, okay, I will think about it. Then you can say, okay, so, you can discuss whatever, and then you let us know what you would like us to do. If she still is, saying, well, no, then you can say, so as long as you understand, delivering outside the hospital, from the consultant-led care, carries the risk of life-threatening risk for you and your baby. If you still want to consider that, how you feel about delivering on our midwifery unit. So there is a unit which is next to the hospital, but that's completely run by the midwives. You will have natural home-like environment in the room, normal bed. You can bring your pictures with you. You can have a music of your choice, and there won't be any machines or monitoring anything done in there. Although we strongly recommend you to be monitored carefully and continuously. But if that's what you want, then that can be an option. At least, there, if you start bleeding heavily or if there are any concerns about the baby's well-being, then we can immediately transfer you towards the consultant-led time where all these facilities will be available to look after you and your baby. Okay, so give that option. If she still says, no, well, now, I don't want to do that, I want to deliver at home, then the answer is okay, as long as you understand all these, and you still want to go ahead with the delivery plan at home, I will go and discuss with my consultant, inform the consultant about your plan, and then, I will let you know. We will arrange that accordingly. There is no place to say, I'm going to make your appointment next week. The appointments in the clinics is very difficult. It's so long waiting list. So we see at 35 weeks and then we make her to see 36 weeks, very next week to be seen by consultant. No, that clinic is already overbooked or overflown. Okay. So if we need to discuss with the consultant, you as ST5, your consultant will be in the clinic in some other room, seeing some other patient. So you will go and discuss with the patient now. So, and then you will make the plan, whatever, if she wants to go ahead with the vaginal birth or whatever. And if consultant wants to go and have a word as well, the consultant will come and do. So don't rearrange next appointment. That means you actually are not reaching what you showing it that you do not have the ability to reach to some decision with the patient. Yeah. So you're just kind of shifting that discussion or responsibility to another clinician. So come next week and speak to the consultant then. No. All you need to say is that's all you understand, then I will go discuss with the consultant and then we will put your plan of care in place.
But Dr. Sophia, if she's already saying I will come in 5 minutes and in any case she wants to deliver at home, so what we are going to discuss with the consultant? And if we know the risk, same the consultant will say to us. So then what after the discussion with the consultant?
Yeah, so that's why I'm saying we don't need to put another appointment. So we still have to take all that discussion with her. But we need to go and inform the consultant. Okay, the reason what we need to go as a ST5, anybody, even straightforward, willingly somebody needs electrocesarean section, and you want to book that cesarean section, you need to go and tell the consultant anyway for blah 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 blah. This is patient, and she's for electrocesarean section, because consultant need to know who will be coming on her list. That needs to be in her diary as well, right? So any these type of admissions, any procedures, anything you will be discussing with the patient to inform, sorry, to the consultant to inform. So that's what you will do. You will go in there to the consultant and you will tell this is blah blah blah. This woman with these respecters, she want to do this. I have explained her these days. She still want to go ahead with this one. So because she needs to know there is a high risk. So although we have told her, we have strongly recommended her to deliver in the unit, but if she's not delivering, we're not just going to leave her. We know how to make whatever the possible safest care plan can be in place. So that's why also consultant need to know, the midwife coordinator needs to know, they all will need to know. Then there will be kind of a multidisciplinary plan. So that we can just make sure, yes, the senior midwife or two midwives maybe attend that delivery. We might have ambulance on call as well. We will be like, so when the midwife goes, she's in labor, they will actually alert us by saying this patient actually is in labor now, so that we are aware as a registrar, as a consultant, to make sure that she is progressing smoothly. And if there is any problem, maybe discuss with the midwife to again encourage her to shift to the hospital or blah blah. Or if she's coming to theater, then if she starts bleeding, we have a low threshold to be prepared, you know, for the necessities, and all of us to make sure that if this woman needed to be 36 BMI is a very high BMI in pregnancy. Yeah. Are these BMI. So she will be a very high risk woman delivering at home. So we actually all need to be alert. So your consultant needs to know this plan, which is different
Okay,
from the
this is
standard.
just for the consultant to know that if she will come in emergency, so she knows the case already.
Yes,
Otherwise, there is no possibility that she will come and counsel again, or she will
Okay, so
come.
don't worry too much of these depths, Sajila. Don't worry about these deep stress, what consultant will do. All you need to say is I will go and discuss with the patient and inform about this plan, okay? Because you need to inform the patient, consultant then and there, this patient is going for this, because it's ultimate
No,
is
because
consultant's
of
responsibility.
you told her, na, what consultant will again, she will talk the same to me, which midwife talked to me, and you talk to me, and she will again,
Yes,
you're putting,
yes,
yeah.
yes, exactly. And
That's,
that's why I said because
yeah,
to me as a patient, if you're not giving any plan on that
yeah.
day, all you're saying to me, I'm going to arrange your appointment to come next week, I'm fed up. This is what I will
Yeah.
say. That's why there's a different thing what I'm saying. You need to tell
Mm-hmm.
to the woman, okay, now I'm going to inform the consultant about your plan, okay, and then I will come back and put your you know, all the delivery plan and care plan in place, because then we need to write down in her notes, on her
Yes,
antenatal notes, what the plan is. Okay, so
exactly.
this is different what I said from what you are saying, right? So you will just literally go inform the patient, the consultant, and then
Yeah.
it's sometime, I mean, everybody is different. So this testify maybe as competent as Dr. Jabin, okay? And I consultant, as being consultant, I know I can trust actually on the counseling of my registrar. I know, yes, she would have done excellent standard. Then I might, you just come in and you tell me, and I will say, no, that's fine, Dr. Jabin. If you have done, then have you informed blah, 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 blah. These risks, he says, yes, I have. Then I will say, yeah, that's fine. Okay. You know, do that documentation, put in there, and then inform
Understand.
the coordinator as well and put the plan. And I may not bother actually to come out of my room and go and speak to the patient. But if it's my junior registrar, some like ST3 or ST2, although she might come and say, I have told everything, but I don't know how she has told and has the patient taken though. In that case, I might like actually to come and speak 5 minutes to that woman again.
Exactly.
Okay. Yeah. So let's keep these things simple. Don't worry about these. Will consultant come right at that
This is
time or
just to
not or whatever.
answer, like, we have a clear idea that what is going
Yeah,
on.
yeah, yeah. This is how it will happen. So for everything, for any these plans, you know, even for any straightforward cesareans, when you book, you need to then and there go in the clinic and inform the consultant that this plan we have made for you, and we are adding this person to the list.
Yeah, that is fine.
Okay.
Okay, thank you.
Dr. Safia, one doubt, like, do we really give them the option of the midwifery unit? Because if they might find it difficult to monitor the fetal heart continuously, they will not start a IV line. So why are we giving the option?
I love you all. So
Sorry.
no, we are not giving an option. We are not giving the option, right? So you start the first 8 minutes. I am all telling her it's not safe. We do not recommend you to deliver at home. When we talk about was when after all that, she still said, well, I know, but no, I want to deliver, still I want to deliver at home. Then what I said, as long as you understand that your decision of delivering at home carries life-threatening risk for you and your baby, if you still want to go ahead with that, that you don't want to have the consultant-led unit, how you feel about then delivering on the midwifery unit? Because no, what I'm doing, she has clearly told me, do whatever you want to do. I'm not coming to consultant-led unit. Okay. Then at least no, I will try to, and I'm not just going to do my hands like, clean with the and leave and say, okay, that's fine then. Do whatever you want to do. No, still she is our patient. Still we will like to do then at least what still maximum we can do best for her. So in the midwifery unit, we are bringing her, but all we said was, yes, we won't be able to monitor your baby or anything, but at least when we have any concern that you start bleeding and anything, then we can at least shift you quickly.
Okay.
Right, so transferring from home and transferring from just standby midwifery-led unit, and that just is literally,
Yes.
the other end of the corridor, basically. Then we're not going to send her to standalone midwifery unit. Okay, so if that's your
Okay.
question, is yes, there's
Yeah,
a
yeah.
difference. One, a standalone midwifery unit, we're not going to offer her there because that's not going to do anything different from delivering
Oh,
at home. This one is where we have that on the unit. We still have, edges and yeah.
okay.
Okay, next one.
And the same time, we cannot get the anesthetist also to see. We have to wait for 36 weeks. That day, she cannot be seen. Meaning
No,
today,
and
when
this
she.
statist is doing his own thing somewhere else. So this lady will need have an antenatal check in 36 weeks anyway. So we can't bring the anesthetist to leave everything he's doing and just see this patient in our antenatal clinic. So there needs to be a separate appointment anyway. Okay. Right. Okay. So I have lost my CMV slide somewhere. So who is next? I'm going to dictate you the scenario.
Sujata.
Sujata. Hello, Sujata.
Yes, Dr.
Okay,
Safia.
Sujata. Please don't take that I'm getting angry or something like that. I'm not losing my temperament. I'm just trying to stress the importance of points, okay? Please. So nobody take it personal, please. Right, Sujata. So okay, the scenario for you is then I think I've deleted that slide somewhere. So you're asked to say 30 years old, Catherine Wills. She is 24 weeks pregnant, admitted yesterday with fever and a sore throat and rash on her body. So we have done the blood test. We did like full blood count, UNEs, and we did some viral serology as well. So full blood count and her UNE stuff, that all is normal. Rubella antibodies positive, detected, yeah. And then you have cytomegalovirus. There are two results for that. Okay, so one is from yesterday where IgM is positive and IgG is positive as well. And then you have the second result, which was done in the booking bloods, which shows no IgG detected for CMV. Okay. So your ST5, your midwife asked you to come and see this woman. So your 2 minutes start now.
Okay, you can start.
Yeah, one. Hello, I'm Dr. Sujata, one of the doctors in the ward today. Am I talking to Sharon Williams?
Yes, doctor, my name is Sharon Williams.
And how may I call you?
You can call me Sharon.
And can I confirm your age, please?
Yes, I'm 30 years old.
Sharon, I see from your notes that you were admitted yesterday with fever and rash on your body, and you are 24 weeks pregnant. How are you feeling today?
I'm not too bad today, doctor. After having the paracetamol and some rest, I'm feeling a lot better today.
Okay, and is the baby moving well inside?
Yes, I can feel baby movements.
Is there any other problem, Sharon?
No, that's all, doctor. Obviously, I'm 24 weeks
Okay.
pregnant, and I'm really worried about my baby in pregnancy.
Okay. Yeah. So I see that you have done some tests and you would be wanting to know about the results. Is that right?
Yes, doctor. They did some urine tests and some blood tests yesterday, and yeah, the midwife told me that you guys have the results, and then she said doctor will come and let me know.
Yeah. So Sharon, your some of the urine test is normal, and the blood test, some blood tests in which we see how much hemoglobin is there in your blood, that is also normal. And we have done some viral tests also. In that, rubella test shows that have you are immune to rubella. You have had this infection before. And then we have done another test called the cytomegalovirus because you had this fever with rashes. So that is one cause for the fever with rashes, and we have done it, and it shows that uh, you have uh, you have had this infection recently.
Okay. What does
I,
that
I
mean, doctor? Yeah.
Yeah. So you have got this infection recently. So can I ask a few questions because this infection can affect your baby. So I would like to ask.
Yeah. Yes, please, doctor. Yes, you can ask me what you need to.
So is there anybody else in the family? Like, is this your first pregnancy, Sharon?
Yes, this is my first pregnancy, doctor.
Okay. And did you come into what do you do for a living?
I'm a school teacher, doctor.
Okay. Did any of your students have any fever with rash?
Yes, a child was ill with some rash and fever a few weeks ago in my class.
Okay.
So I'm worried I might have caught this from him.
Do you have any idea what infection that child had?
No, I know I should have tried to know, but no, I didn't. I didn't contact the mom to know what it was because I thought at that stage he has a chicken pox, and I mean I had chicken pox twice when I was young, so that's why I didn't really I didn't think anything about about this.
That's all right, Karen. Okay. Is there any other? How has your pregnancy been till now, Sharon? Otherwise,
It was pretty straightforward. I don't have any risk factors and anything like that at all. And I was booked under midwives. Yeah.
okay. And you don't have any medical condition for which you are treating with a GP?
No, doctor, no, nothing. I'm pretty fit and healthy.
Any surgeries you have had?
No.
Sharon, are you all right?
Yeah, I'm okay. Obviously, I'm just feeling a bit unwell, tired. Yeah.
Okay, so do you have any allergies, Sharon?
I do have an allergy to plasters.
Plasters. Okay, I can note it in your book, but how did you find out that you had allergy to plaster?
I had I had a blood test done in the beginning, and I had a reaction to that. I did have when she put the plaster afterwards. My arm went really red and swollen there, and quite itchy as well.
Okay. Are you well supported at home, Sharon?
Yeah.
And is there any history of clots, family history of clots in your legs or lung in your family? Sharon, is it
Yeah.
okay that I can talk?
Yeah.
You're
Yeah.
not.
I'm fine, doctor. Yeah. You can ask me
Okay.
what you. Yeah.
Yeah. So, okay. Then thank you for the information. Coming to your test, this looks like you have a infection with a virus called the cytomegalovirus that it can be passed on to your baby and it can affect the growth of your baby.
Okay.
So we should be doing. We'll be offering you serial scans from 26 to 26 weeks onwards to see how the growth of your baby is, and
Okay.
then but otherwise the pregnancy can be straightforward, and maybe when the baby is delivered we have to see whether this virus has affected the baby's hearing, because usually it affects the hearing of the baby, and sometimes it can affect the vision also. So these are the two things that we have to check when the baby is born.
Okay.
And as such, there is no treatment for this virus, so you are feeling little better with your paracetamol. So that is how we'll be managing you. And once you get better, you can go home and then come for
Okay.
follow with the consultations that we'll be giving you.
Right. So you said, this infection could affect baby's hearing. So is there any test you can do to check if the baby is affected by the infection or not?
Yeah, so we can be referring you to the fetal medicine unit, and we have this fluid around the baby. So if we can take the fluid, we can see uh, how the baby whether the baby has been affected with this infection from the cells in the fluid. So that we can refer you to the fetal medicine unit consultant, and
Okay.
they should be able to help you.
Right. Okay. And when that test will be done, doctor?
After 4 weeks, because it will take some time for the infection to be manifested in the baby. So after 4 weeks, we'll be referring you to the fetal medicine unit, and they will be doing this test.
Okay. Right. So the only effect your baby had from this will be the baby's hearing may be affected.
Yeah, the growth also can be affected. That's why we'll be doing the serial growth scans. But mainly it is either the hearing or maybe the vision.
All right.
So the
Okay.
medicine, specialist will be able to guide you better, and I can fix an appointment with my consultant as well and give you the written information so that you can go through it.
Okay.
Is that right? Is there any other concern?
No, that's, I mean, that's all. I was just worrying about, you know, I was just reading about different type of these viruses and stuff, and I was really worried if it could do, you know, more damaging harm to the baby.
Yeah, this is what I know. I can refer you to the fetal medicine consultant, and they will be able to guide you better.
Okay.
Once you are better, we can discharge you and come for follow-up with the fetal medicine consultant and for the serial scans. Is that
Okay,
right?
Doctor. Yes, Doctor. Right. That's fine. Okay.
Is there
Yeah.
anything else?
Yeah. I mean, is there anything else you want to add, or you think you're done?
Yeah, I'm done because I know only this much, Dr. Safia.
Okay, that's okay. That's okay. I know this case was not, I think, in this particular recording you guys have to prepare. And maybe there's some other what I have done with that slide, I don't know. Okay, so cytomegalovirus is one of those serious infections which can cause a lot of abnormalities to the baby. And it is also one of those serious infections as well, in which, because the damage can be so severe. Yes, there is one, obviously, these children can have deafness, and that deafness, obviously, we cannot pick, obviously, before the baby is born. So that's one thing we need to tell them. There is quite a high risk of this deafness these babies will have. We need to tell them very clearly that it will be a deafness, okay? And the second, we need to tell them there is like this: a baby if the infection is passed on to the baby, then if the baby got affected, that can range, that effect can range, in different levels. So one can be that the baby's growth and baby's development and nothing is being much affected after the delivery. But yes, baby's hearing might be, which we obviously be checked after that. But on the other hand, we know this can actually cause quite a lot of severe brain damage. It can cause calcification. It can cause it can cause ventromegaly. And that can be even to the extent which may not be compatible with the life. So we need to tell her that we will need to monitor that. And then we need to, this is one of the conditions again, as like we need to actually talk about termination as well. So by explaining her all these damages, then we can tell her, like, due to the uncertainties of these damage, and because all of these we may not be able to even pick up by these scans, some couples may decide to go for a termination for that reason. Okay. So the immediate one will be obviously yes, to refer her to immediately to fetal maternal medicine. So the history taking in the beginning, that was fine. That was good to ask about any exposure, any rash. First of all, just establish your immediate well-being. How your fever? How your rash? So have you been able to eat and drink? Have you been able to pass urine? Have you been able to open your bowels? Do you have any cough or any difficulty in breathing? Yeah, because in pregnant women it can cause even pneumonia as well. So we need to just make sure that those all are fine, and she's doing okay. And then you will say, so because of your fever, we did some tests yesterday. We did some blood tests and we took a urine test as well to try to understand what could be the possible reason of this rash and fever. So, so your urine test is normal. So there's no infection or any problem with your urine. We did some other tests to check your, the blood cells and your liver and kidneys function. All those tests have come back clear and negative. We also sent some blood tests for to check for the infections with certain viruses to see if it was some possible viral infection So the viruses we did, one we checked was called rubella. The test we did for rubella was to check if you do have the antibodies or protection against the rubella virus. So that shows that yes, you do have those antibodies and protection against the rubella virus, which is good. Then there was another test we sent for another particular virus. We called it cytomegalovirus. And that test has returned back and it shows that you are actually infected with that particular virus. Then once a pregnant woman, if the pregnant woman is affected by the cytomegalovirus, then it's very important for us to know whether it has been a recent infection acquired during the pregnancy, or the infection is old, or you do have, a repeated infection maybe, and if you had any previous infection, then your body produces protection and antibodies against that virus. And due to those antibodies, then you will be able to pass those antibodies to your baby. So the risk of transmission of that infection to the baby will be low, and the risk of, damage will also be low. So we did check that as well on your booking bloods, when we did blood tests in the beginning of your pregnancy to find out if your blood did have the antibodies or protection against this particular virus at that stage. And I'm afraid your blood shows there were no protection or antibodies against the virus present at that time, which means this infection has been recently been acquired. So there can be a quite significant risk that this infection can be passed on to the baby in the womb. So what I'm going to do now is we're going to arrange your immediate appointment with our specialist doctors. We call them fetal-maternal specialists, because now they will be you will require a close monitoring for your baby, because this infection can affect the baby in different ways. So it can affect, starting from simple things, it can affect the baby's growth. These babies may grow much smaller than the average babies. The damage and harm to the baby can again varies. Some babies who are infected with this may not have any problems at all. They may not develop any complications at all inside the womb or after birth. However, a significant number of babies infected by this infection can have, their hearing loss. They can have deafness, and they can have a vision loss as well. And some babies can have effect on the development of their brain, kidneys, and the bowels can get affected quite seriously and significantly, to the extent where actually the damage may not be compatible with life. So because of these serious complications, or because of the uncertainty and difficulty to completely assess the damage being caused, some couples may, sometimes decide to go for termination. So be gentle, be slow to say this particular sentence, and again, make it as a generalized information. Don't particularly say to her that you may consider termination. No, just simply say because of these. Some couples do consider for termination. And don't ask about that, how you feel about it. We do not want her to give that answer at this stage at all anyway. Okay, so then we will say, okay, so what we will do then, it can take up to about 3 to 4 weeks before actually we can do a test to find out whether the infection has been passed on to the baby or not. And that test is done by taking a small fluid from around the baby and then check there for the presence of virus.
Okay.
However, as I said, like sometime we may not be even to pick up whether the baby is infected or not, even with that test. And sometimes even if we have picked up, we may not be able to get an idea how much damage this will cause to baby. So for that reason, you will be having regular scans and repeated scans by those fetal-maternal medicine are those from the specialist consultant, who will be monitoring baby's growth, and also they will be closely monitoring the effect of this infection on baby's brain and other organs of the body. This infection can damage baby's brain by causing some, we call it calcification in the brain, or try to, it can damage by, increasing the fluid accumulation inside the brain of the baby. And because of that, it can, damage the brain tissue, normal brain tissue, and as a result, obviously, either this damage can be so severe that it may not be compatible with life, or it may not affect the life of the baby, but the damage may lead to very serious learning disabilities and even physical disabilities as well. All right. So, so anyway, you will be monitored quite closely. They will keep you informed and give you full information and support. As the weeks of your pregnancy will progress, and obviously they will keep you updated about any visible damage they can find on the scans. If hopefully things keep going straightforward, then you will have one specialist scan of the baby's brain when you are 34 weeks. We call it MRI scan of the baby's brain to assess again in more depth and detail about any possible damage to the brain. And then if things go again, in straightforward, you should be able to have a normal vaginal birth. However, the baby will need to be seen immediately after birth by the baby doctors to check for any, damage to the baby from the infection. And obviously, they will also arrange the hearing test for the baby to exclude any deafness or any problems with the baby's vision. I will also give you written information about this, and then obviously after listening this all, this woman obviously is going to be devastated. So just make sure by saying that, would you like me to call your partner, or would you, would you like me to arrange some counseling for you? I can see obviously it is very devastating and difficult, or a stressful situation for you. So if you feel it may be helpful, we can arrange your appointment to see one of our counselors, and then give her written information. Quick questions.
Hello.
Yeah.
I have one just clarification that we will say booking blood test. Always we give the reference. Usually we cytomegalovirus we are not doing at booking. So once the patient will get current report cytomegalovirus positive, then we will do the booking blood test.
Yeah, that's right.
Okay, and so means every
So this is the
lady
blood
who
test.
in the
So the pregnant women, the initial bloods which are taken at the time of booking, they stay for throughout the pregnancy in the lab. So, now when we file, we will just ask the lab, we will request the lab actually to run this test on those booking bloods. It's not part of routine antenatal screening. Otherwise, yeah.
Okay, because we are not doing this practice, so I want to clarification.
Yes,
Thank you,
absolutely
doctor.
fine. Any other question?
Yes, supposing, meaning I don't know the full this thing implication of it. Like I should at least have that empathy that I am giving a bad news and said something. Is it? Like if I don't
Yes,
know
it
that
is. It is one of those bad type of templates. Yes, because it's one of those serious infections which causes a lot of congenital problems.
Okay.
Yeah. Okay. Sajila, do you have any question?
I am with the patient, doctor.
All right.
If I have question,
That's fine.
I didn't hear it properly. I will listen to the message.
All right. Okay.
Dr. Sophia,
Yes. Okay. Yes.
because I left for a while, I didn't hear all the station. As regard patient management symptomatic treatment, is there any antiviral, or shall we give her like supportive treatment only, antibiotic?
Okay. So yeah. So mainly it is supportive treatment. the treatment we if we really need to give is self-limiting. Yeah, all of these viral infections, they are self-limiting, and you just give them a supporting treatment. Valacyclovir is the antiviral which can be given, but that usually still is not quite commonly used for this purpose. It's more like in the trials and in the studies for this particular situation. But yes, valacyclovir is the antiviral which will be given if she's not like recovering within 5 days and she's progressing to some serious complications like pneumonia or anything like that, then yeah. Yes.
When the patient is given, have to rule out all the other. We have to ask questions about how bad she is, like, because you said that you're feeling better. Still, I should ask about breathing difficulty and difficulty in passing urine, everything.
Yeah, that one you need to ask, because again, the other important thing here is that we can't just think, okay, she's unwell just because of this viral infection. There might be some other infection going on, or this virus has already might have spread and caused her pneumonia. So you need to ask about any stinging, burning, passing urine, any problems in that, and have you had any cough or any, so that will come in immediate well-being.
Sure. Okay.
Right.
Sapna.
Ramila, how many
Last
stations are we left now?
one more, madam.
Last.
Sapna.
Yeah. Come on, who wants to do the last one?
Sapna is this.
Sapna.
Yes, hello, ma'am.
This is for you, darling.
Okay. Shall I start?
You can start if you're ready.
Okay. Hello, I'm Dr. Sapna, one of the doctors in the triage. May I please confirm your name and age?
Yes, doctor, my name is Anna Linder, and I'm 20 years old.
Okay, how would you like me to address you?
You can call me Anna.
Okay. So, Anna, I understand that you are here today since the GP had, since the midwife had some concerns about you. So, and you have been having this lower tummy pain on and off. Is it right?
Yes, doctor. Yes, I'm having this pain. I think this is about the fourth time I have come with this pain. But every time they can't find the reason. They tell me that there's nothing wrong with me and I'm okay. But I do get really bad pains in my tummy.
Okay. Okay, and I really I understand your situation. So before we discuss what can be done for you, is it okay if I ask you a few questions so that I can know more about your pain and help you with that?
Yeah.
Okay, and can you please tell me more about your pain?
So the pain is all over my tummy,
Mm-hmm.
and it comes and goes,
Okay.
and it can be really bad.
Okay. Okay, and what do you think? I mean, is it associated with any problems with your water works or bowel works, and any associated bleeding or discharge?
No, I don't have any bleeding or discharge. I mean, I do have
Okay,
discharge, but I think that's normal in pregnancy, isn't it?
okay. And what about the baby movements?
Baby is moving okay.
Okay. Do you have any idea why you're having this pain?
No, I don't know. I mean,
Okay.
maybe because of the pregnancy, and that's why I come to the hospital, but the midwives can't find. Every time they
Okay.
tell everything is okay, everything is normal, but
Okay.
I'm having these pains. Yeah.
Okay. So, can you please tell me more about this pregnancy? Was it a planned? Is this the first time that you're becoming pregnant?
Yes, this is my first pregnancy.
Okay.
No, it wasn't. It wasn't planned.
Okay. How does your partner take? What is your partner's take on this pregnancy? Is it a welcomed pregnancy? I mean, now that you
Um,
have become pregnant.
um, Sorry, doctor. Can you explain again what you want to ask?
It's okay. We'll just come to it. Other than this, have you been visiting the GP for any other medical conditions in the past?
No, doctor, I'm not seeing the GP for anything else.
Okay. And have you undergone any surgery in the past, in the tummy or down below?
No.
Okay. And what do you do for your living?
I have just left the college. Um, so
Okay.
I'm not really doing anything at the moment. I wanted to do a course in hairdresser. But no, I haven't started yet, and then I got pregnant.
Okay. And are you aware of your weight to height ratio?
Yeah, it's 19.
Okay. Are you into habit of smoking or drinking alcohol or any other recreational drugs?
Um, I don't use any drugs. Smoking, I do. I'm trying to cut down, but I'm still smoking a bit. And no, I don't drink alcohol.
Okay, so smoking is really harmful for your general health as well as for your baby. So if you really consider this, I mean, we can help you with the NHS stop smoking cessation program. What do you say?
Uh, yeah, my GP told me. Yeah, I will.
Okay, good.
I will stop smoking.
Okay, so we'll help you with that. And how have you been feeling in the past few weeks? I mean, do you feel low or lack interest on doing anything?
I'm Yeah, I'm tired, and then I'm worried about this pain and.
Okay.
Mm,
Okay. So we'll help you with that, Anna.
thank you.
Now, the midwife had examined you and noted that baby is growing fine, and the CTG, that is the graph of baby's heart, was also taken, and this was also found to be normal. But at the same time, she also informed me that she had noticed bruises and scars um, on your inner little bit thighs and concerned about that, and I'm little anxious about that. So can you please tell me how have you got these bruises?
Oh, those bruises, I just fell down, doctor.
Okay, okay. And did you have any, did you attend a hospital or the GP for the same?
No.
Okay. So, I just need to tell you that, in our country, unfortunately, 1 out of 4 women, they suffer from domestic violence. And, this violence against these women, it is something that shouldn't happen. And I assure you that whatever information you give will remain strictly confidential between you and me. And we are here to listen to you and support you. Uh, and just one question: do you consider yourself as a happy couple? I mean, has your partner ever abused or has been violent towards you?
I don't really want to talk about this all, doctor. Can you sort out
Okay.
my pain and I want to go
Yes,
home.
definitely. Yes, definitely. And we are here to help you. But may I just know the reason why you don't like to disclose this? I mean, probably that could be there could be some thing in a we can help you in that way if we get to know what is really happening. And your safety and your baby's safety is of utmost priority to us.
I mean, I'm just a bit worried if I, do share anything with you, then obviously, you're gonna speak to other people and stuff, and then I might end up in more trouble. I don't really want to take any risk. I know there isn't anything which can be done anyway, so I would rather not, go into it.
Yes, Anna, I totally understand your concerns and anxiety, but we do see people who have been suffering from domestic violence in our clinics, in our day-to-day practice, and we have been, being able to help them in whatever way we can without revealing the identity. And so if you are really, I mean, we are really, since we are really worried about your safety and your baby's safety, uh, if you could tell me what has really happened, probably we can help you without putting you into more threat.
Yeah, my partner is quite he's quite aggressive at times. Actually, he just doubt me all the time. He keep blaming me that I'm cheating on him. I'm not. Even if I go out to see my mom or if I speak to my friends, he just shouts, thinking I'm just talking to another guy. And then, he goes a bit aggressive. And so these bruises down there, I just lied to you that I fell down. No, I wasn't. But just like he pushed me and then, he just tried to hit me. So I'm really worried about my baby as well.
Yes, and I'm really sorry to hear that, but then I assure you that this will be confidential and we'll try to help you in whatever way we can. So, how long has this been happening? Have you ever told this to anyone, any of your friends or family members?
No, I haven't, because he's gonna go really mad if he came to know. And
Okay.
I mean, I can't go much out anyway to see my friends. I hardly see my family even. He doesn't like me going out. He doesn't like me seeing my family. So I'm not.
Oh, okay. So, Anna, what we can do is we have one thing is we can send you home with some escape plans, or the second one is if you feel you are not safe to go home, we can admit you and taking you into our safe custody. And so, do you feel safe going home?
Um, yeah, I mean, yeah, I will be okay.
Okay, if that's the case, then I would suggest that you keep some the contact numbers of the police and the social services, and even we have the 24-hour domestic violence helplines. You probably you can hide this along with your cosmetics or some kind of things which do not expose it to him, and your partner doesn't take a note of it. And also I would suggest that you keep a spare of your your spare clothes and copies of some certain important documents like the passport, the driving license, etc., in case some life-threatening attacks ever happen. Okay.
Okay.
Okay, so if you don't feel safe, then probably we'll admit you, and we might have to inform various organizations. So I'm going to document about this domestic violence in the hospital notes, but not in your handheld notes. So any queries, Anna?
No.
Okay. So thank you for opening up and coming up with your personal issues. I'll definitely help you in this matter. Okay.
Thank you, doctor. Thank you. Okay.
Okay. Thank you.
Thank you. Okay, so this one was straightforward. They already gave in your task about talking about the domestic violence, so you knew exactly what this case is.
Yes.
But actually, if you just hide this lower part, then it can be quite difficult. Yeah, but obviously there are a few suggestive stuff here. Yeah, the repeated admissions in pregnancy and even otherwise repeated hospital or clinician visits without any clear reason and cause, and then vague symptoms, not going anywhere, and then presence of bruises on type of on the body parts which don't go to the picture with the patient is telling us. Apparently he has, she has fallen down. I mean, how likely is to get the bruises on the inner thigh by just from natural falls? So obviously we will be thinking more about domestics that should provoke, and that's the reason we asked that direct question from the patients by thinking, do you feel well supported, safe and happy with your partner? Yes, so the history will be to start with in the beginning, or you can say you start by saying, because here you already know about the domestic thing. If that's given already clearly, just start with establishing the trust and say, so I'm asked by the midwife to come and see you. I assure you that everything and this whole discussion will be quite confidential, and it will not be shared with any third party unless you will, unless I have any serious concerns about your health or your safety, and that will also be done with your consent. Okay. And then you will start asking by saying, okay, so I can see you're 32 weeks pregnant and you came with some pain. Tell me, in more detail about your pain. Is it the first time you had a pain, or you had this pain before as well? So if obviously this lower bit is not given, then you just simply start with asking, just the routine questions about the pain. How bad the pain is, does it go anywhere, radiate anything, make it better, any feel it, any unusual discharge with that, any stinging, burning, any cough, anything you have, any fever with it, if it's already not telling you domestic violence. Because don't just get by seeing those bruises down there. She might have some real reason of pain going on as well. Yeah, so just ask those quickly. There's anything like that, and what have you done? Describe the pain, and that will be the presentation will be vague. It's all over. Does it go? No, it's there all the time, and it does. Yes, I came. The midwives say they keep saying there's nothing wrong. It's all there. Then if the patient is just literally going vague about things, there is something else going on. And then there are, obviously, you can just again still ask those 3 questions we do. Risk of VD assessment, because she is pregnant anyway, although there is domestic violence going on as well. And about the family history of those. She's very young girl, obviously she can be at risk of preeclampsia as well. Ask her BMI, ask about her pregnancy has been otherwise still so far. Any problems she had, high blood pressure, diabetes, anything, her test been normal, her 20-week scan, is that okay and normal? And then you take and say, I can see you're very young. Yeah, that's very good way to open up the way. I can see you're very young. So what support have you got in place to look after you in pregnancy and also your baby afterwards? And you can make her to open up, yeah? For these people, young people like right up to 19, 20 years, it's absolutely okay to ask them as well, who are you living with? Because they may not necessarily be living with the partners, but they might be living with the partner or with the parents, yeah? And then ask, does your mom and your family supportive in your pregnancy? And they're supporting, and they're going to help you with the baby as well. And then come straight forward to the partner to say, what is the response of your partner towards your pregnancy? Is he really happy? Is he supportive? Is he willing to look after the baby as well with you? Just ask very nice open questions. And then you can proceed further, and then you can ask, obviously during that time you will get some clue anyway from the partner. Okay, no, it was an unplanned, it was not planned pregnancy, it happened, my partner wanted to. It's not unusual. They give the history to say, my partner wanted me to go for termination, but I didn't want you to do it. So he's not happy, because they feel there is some reason why the partner is unhappy and causing domestic, their violence to them. So sometimes they just keep justifying the wrong doing of the partner. So he goes angry because he doesn't want to, and that should make us then to pick up, that even if there is a reason or whatever, still obviously that person is not supposed to do any violence on that girl anyway. So then you need to ask about, and I will be very open to ask. And then, okay, if she's still not open up, ask about by saying, no, the midwife, she has examined you. She has informed me that you got some bruises on your inner thighs and the arm as well. And I'm really concerned about these bruises being in that position. So would you like to tell me exactly what happened? How did you get these bruises, right? And then she said, well, I fell down and that's what. And then you can say, well, okay, I mean, that's quite unusual place to get hit or get bruises on if you fell down. And then I will be very open to say, well, I would like, Anna, you to share with me if there is any other, reason for these bruises, because I'm really concerned about your safety. And then it was okay to say that way by saying it's not unusual for pregnant women to suffer from domestic violence from their partners or sometimes some, other people around them. So is there anything like that going on with you? Okay, so you can just, so you want to say 1 in 4 women in this country go in violence, it's okay, you can say that. Otherwise, again, if you want to keep it a simple conversation for that young girl, just say it's not unusual for many women to suffer through the domestic violence from their partner or for some other people around them in the pregnancy. And I do have really serious concerns that, that your bruises and in the thighs might be the result of the violence. So I will encourage you please to share that information with us. And if she doesn't open up and she still says, well, no, I don't want to, tell that I will be in trouble and all that, so you can say, I can absolutely understand your this concern, and you are right. If you come to know that you have discussed with anybody, or if you try to do anything, then yes, the risk is, that he may become even more violent, and that can be even life-threatening for you or for your baby. So for that reason, do not worry. We have specially trained teams to deal with these issues. As I explained to you, that it's not uncommon for the women to suffer with the domestic violence. So we do have our specialist trained people who deal with this in a very sensitive manner. The way they will approach, they will make sure that your and your baby's safety is not compromised. How you feel about. So I feel you were good in taking history. You took quite long to reach and ask me an encouraged direct question about opening up the domestic violence. But then after that, I didn't find any support. I mean, as you are telling me to keep those things and keep the phone number with you. No, before that, we need to do something straight away here, yeah? This 32 weeks, she's due to deliver now soon in next 6 to 8 weeks time. So this baby is at home as well. So there is a safety of mother and safety of the baby at stake here. We need to take action immediately and need to take action now. So Ambe will actually openly encourage her to say, would you, like us to do something about it. We do have this team, and they will deal it in a very sensitive and careful manner without putting your any additional risk to your and your baby's safety. If she feels like that, and if she says no, no, I don't want to do that, and I might go, no, he will be all right and stuff. Then we need to actually make her to understand that these type of whatever he's doing actually can result in serious harm to the baby. Okay, so I will then open up and I will say, okay, I can see you are scared and you don't want to take any action. However, Anna, you and your baby are really at a high, serious risk of harm. Okay, if you become violent, and the way if he's kicking you or hitting you, look, I mean, you have these bruises just on in your thigh. If his kick would have gone on your tummy, that could result in a serious harm. That could result even in the separation of your afterbirth or your placenta, and that could, lead to heavy bleeding, which could be life-threatening for you and your baby as well. So, I will really encourage you that you take help, and we can give you the help, and we will provide you the help in a very safer manner. Okay, so then you ask again how you feel about it. If you're happy to take some help, we keep you here for the time being till we actually get that all support available and arranged for you. I will speak to my consultant. I will speak to the safeguarding team of our trust, adult safeguarding team of the trust, and then we can put appropriate support in place for you. Okay, and then and we can also make a long-term plan for the care of your baby as well. Because if it kept happening, even if you are okay to get up to your delivery, then he might cause some harm to the baby as well afterwards. If he becomes so aggressive, when the people get very angry and aggressive, they lose the awareness of what they're doing and what consequences can be. Right? So bring the baby in. That will encourage her to take some action about it. And tell her, like, we have a safeguarding team and we will just arrange that all safely for you till delivery and afterwards as well. If she says no, then obviously we don't need to go into that. But then you will still say, we will encourage you, tell that it could happen like that and your baby and, after delivery as well. In that case, then you will say, okay, if you don't feel quite ready to do anything and you want to take some time to think about, it's okay. What I'm going to arrange your appointment to come back next week again. And then we will have a chat again to see how you feel about it, after thinking, and then we can discuss again how we can sort it out for you. And meanwhile, what I'm going to do, I'm going to give the contact details of this service, that is domestic abuse or domestic violence service. Keep this, contact details hidden somewhere away from your partner. If you would like to, you can contact them directly as well when you feel safe to do so. And those people are, again, very well trained, and they will help you in a very careful and sensitive manner. So then they can arrange that support and care for you as well. And then, yes, it was okay to say, if she's not willing to, then you can say it would be a good idea to keep, your travel document and some money, and the key of the door somewhere private and hidden. So in case at any stage, if you feel really threatened and intimidated from him, then you can safely escape from there. Otherwise, I'm going to give you this helpline. You can even call police if you feel your safety or the baby's safety is a severe risk. Yeah, do not take any risks, and it's important that you do something about it. Yes, so that's about when you're talking to the patient, this is what you will explain. If it was a structured discussion, then yes, again, you will again say, you will talk about the, from the history, and this it appears like a domestic violence. Then we'll see in the structured discussion, they can ask you like what sort of hints you can have from the pregnant women when they present, what type of presentation they can give from which you should suspect, and probe further in more detail to find out to exclude domestic violence. Then obviously again these type of repeated attendances and any no particular just vague symptom and no clear explanation of their attendances or about their bruises or any injuries on their body, lack of confidence, obviously low self-esteem. Sometimes they are more likely to be young patient first pregnancy. These are the different type of things that you should keep in mind, keeping your feeling a bit high about to how you proceed. We have just discussed, like, if you have any concerns, it should be a routine part to ask that question to exclude the domestic violence. And if there is any suspicion we feel, it's good to, it's very important that we offer them, promise the confidentiality. We reassure them it will be dealt in a sensitive manner without causing any harm or safety risk, and then encourage them to open up and get help. Anyway, so that was the routine process, what you do. So it's very important you do arrange another appointment after a week or so for her to come back if she's not willing to do something straight away now. Because she go home and she might then think at this stage she didn't come and she didn't expect, somebody will invite her to actually discuss this. So she's not prepared what she actually want to do about it. So she might be prepared after 1 week. So it's very much to see them again after a week time or 2 weeks time. And then what actually happens in structured discussion point of view for this woman, what we will do, we will again make the referral of this woman to Marak, the same Marak we do for child safety, multi-agency risk assessment conference, which again has the police, social services, health, education, young people. All of them are the representative there. They will discuss this case. Then obviously, police, if they need to arrest that person, they will go and arrest. If this woman, because she's adult here, if she says yes, she wants to seek safety and support for herself, but she doesn't actually want to accuse the partner, then police won't go and arrest. He might be given a warning, but he won't be arrested unless obviously this woman wants to put a proper complaint at a FIR or whatever. In the Marak, then they will obviously assess the social services. They will then they might think, plan, arrange the housing for this woman. They will provide support worker. They will also assess the safety of the woman. Is it safe for her to stay in that area then if she's going to separate from that partner, or should she be moved to another area? So all that plan will be put in place. And then even the birth plan, okay, how safe it will be actually to leave the baby with that young woman, what type of support, obviously this woman will require financial support. She will need social support as well, from the point of view, like maybe involving her family. So we will encourage, they will actually encourage go and meet if she has parents, to make some plan in place for her. And also then afterward provide some child care as well, so she can continue with her studies or whatever she wants to do to become an independent and confident member of the society. Okay. But there will be clear child safety plan as well in place, because this child is at risk as well. All right, any quick questions?
Maximum, I mean, we have to make her, I mean, to stay in the hospital, right? No, rather than sending her home.
If she agrees to disclose, and seek help, then we will say we will offer her to stay in the hospital till we get it sorted. Yeah, because then you will need to speak to safeguarding team, you need to speak to consultant, and then we see the plan needs to be in place. And that's because she's pregnant. Yeah, if she wasn't pregnant, if she comes just in a sexual health clinic and she says that, then we won't be worried about to keep her. We will just give her instructions to stay safe and all that. Meanwhile, we make these arrangements for her. But if she doesn't want to, then obviously you will just leave with these safety instructions and invite her after 1 p.m.
Much to tell within this 10 minutes.
I know it's quite a lot. But usually, if it's a domestic violence, if you ask that question right in the beginning, which we have said, and then the scenario gives you an idea. Domestic violence, for exam point of view, they don't make it very hidden on that type of, no. The scenario either it clearly tells you, just like this one, yeah? So then you should know, because there's a quite lot to talk. Just quickly touch the rest of the history. Any problem with this pregnancy test for any concerns about the baby's well-being or growth, that's sorted out this whole pregnancy. The support she has because she was young, mother, family, who is the partner, and then you can just crack on without, okay? You don't need to go about the periods, when was the last period and when were you, all that stuff. No need at all. And
No,
then
but
link that in.
when should we talk about the confidentiality? When we say, when we ask her whether it's a planned or unplanned pregnancy, then and there itself, or after taking in the entire history?
No, so for the confidentiality, otherwise you don't need to worry about it. But when this particular woman, because it's in the scenario already was given down here about the safeguarding, and then the scenario clearly says everything fine and normal, and she has inner thigh bruises. In this woman, you can right from the beginning assure her about the confidentiality. But if it was like something, when you start talking, you do have some concerns in the history, but there's not clearly given in the task about domestic violence, then obviously you need to first bring her that. So you can just simply ask her question, and as soon you find out, you encouraging her to tell, she obviously will give you some clue. It doesn't go, don't worry about like domestic violence or child abuse. If you ask the right questions, and the right questions are simply, which I have told you from safeguarding assessment in under 18, and then pregnant women like this, yeah, or even in the sexual one. If you ask these questions, there is no way they're going to hide from you. They will give you the clue either by accepting it straight away. Yes, there is, but I don't want to discuss and tell anybody because I will be in trouble. Or they will say, I don't want to talk about this. They won't deny it clearly to confuse you by thinking, and then you still keep worrying now that these inner thigh bruises or something. And if you have clearly asked about, do you feel, and I have the concerns about these bruises, because they don't really quite go with what you are saying, like by falling down is quite unusual place for the bruises. And if you still reassure, no, that's fine, doctor, that's exact, that it is. There's nothing else, don't worry. And you ask next question, do you feel yourself happy? And safe when supported by the partner? And if the answer is yes, then it's fine, forget the domestic abuse. Don't just confuse yourself, okay? So actors won't play with you at all. And leave the actors in real world, these people don't. They won't lie in a way trying to hide because they themselves are, are not criminals that they will try to hide it in a clever way. All they do is they will try to hide either. They won't try to hide, they won't bring it to the discussion if they're not encouraged to, if somebody hasn't asked them. And if somebody has asked them and reassured as well, then the second thing is fear. If we did, because obviously these perpetrators always threaten them. If you discuss with anybody or you told anybody, I'm going to do this to you, and you will be in trouble. So when you assure them as well, they say, well, no, I don't want to talk about it. And then you say, then you should know, yes, there is something not right. And then reassure about the safety. Do not worry about that we also understand, yes, discussing this and doing something about it can't compromise your safety. But because we have these specially trained people, they will, do blah, 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 then they will open up. So they're not really that difficult as people might think. Okay,
ma'am.
That's all done for today. And next one will be now maternal medicine.
Hello?
Hello?
Yes, Dr. Safia. If you
Yeah.
told her we will take immediate action if you wish, what is the action we will take immediately?
Yeah, so the immediate action is we will keep her in
So we'll say we keep you here. I'm going to discuss with my consultant and also our safeguarding team. And then we're going to make arrangements for your to assess the risk and arrange some proper and safe place for you to stay, and also put a plan in place for your rest of the care in this pregnancy and also for the baby after born. Okay, this is immediate action. And
Thank
then
you
we're
very
going to
much.
make a referral to Morocco afterwards. All right. Right then. Thank you very much and bye.
Thank you, Dr. Safia.
Thank you.
Thank you, ma'am. Thank you. Good night.
Thank you. Thank you.